to the situation and recover the patient. That is the biggest challenge. Suppose similarly they want anything, but whether it is possible or not within the shorter time, because everybody knows you should not miss the golden time. So now this is the corporate. Everybody is going to get. I am not much interested on dealing with this. Okay, because now even central government, National Medical Commission, everybody is talking about go near to the corner area, go near to the villages, go near to the tribals, go near to the people, those are really deserved for it. But whether you are reaching them, whether your knowledge is useful for them, or otherwise your knowledge is only limited to collect money. Okay, it is collecting money. Yes, of course, even I need money. Okay. Without money, nobody can do it. But thing is, back of it, are you carrying any 10% of satisfaction in or not? That is the most important, that is the crux of the thing. So that's why the telemedicine of India is coming between. It is creating the bridge between the corporates as well as the village people, so that using the telemedicine, using the communication, we are going to help the people. So that we need the communication, we are going to help the people. So that it is an invitation for each and every professional come forward, share, including student. Student may feel like no, so we are not the professionals. You people are also professional, because you are the energy, you are the creators, you are going to make tomorrow India. So if you want to make it, then student has to come forward, and what you want, that has to be expressed to us, so that we'll try to do that. So now it is the thing.
In conducting all this telemedicine part of thing. And one more thing which I would like to share is that ESI has its own portal, health record system, what we call as Dhanvantri. And recently we have been including telemedicine in our portal also. The problem that we are facing in the application of this is that I can say the application should be very much user friendly. There are two aspects in this. One, the person who is sitting the other side is the patient, who should be actually techie friend for telemedicine, which will be incorporated in Dhanvantri and which will be launched very soon, so that we can share our knowledge with all of you. There is one more part which this workshop is going to concentrate on, is the AI thing. Cherry on the top of the cake, telemedicine plus AI is a deadly combination. I agree with that. Yes, it goes very well. As my experience goes in the field of AI, it is beautiful. I would say that in one particular field it acts beautifully, is that statistical evaluation of any data which is being collected in our campus, especially for the research activity. It is very good. But I would say one point is that I would say that AI can never replace a human diagnosis. It is just integrated or supportive part of our diagnosis and treatment. There has to be a supervision of whatever the AI is giving us. I can tell you 1-2 examples. Like we had a project wherein the new prototype of machine was about to launch in the market. It was a fundus camera. The data fed in that camera was basically from the foreign countries. Whatever the demographic data which was fed on that machine was basically from European countries or American continent, North American. And depending upon that, the AI was giving us the diagnosis, which we feel that there was certain amount of difference. This is the one factor which I would insist that we have to take care of it. In order to abolish this, every institute or every healthcare system of ours should definitely give the data of, definitely give the Indian data to whatever the concerned organization or whoever is dealing with this, so that whatever the latest machines which are coming, it should have the Indian data, so that whenever the AI is processing, we will get exact reports, not kind of biased reports. So this is one of the important thing which I request, that data from let it be normative data, but it has to reach to the one place when all this data is collected and it is given to the manufacturer of the machine making. Indian data should be stored at any cost. Otherwise, we always depend upon the foreign data. The second thing is that while application of AI, I feel that yes, it is very super, but it goes wrong in very simple things. I can say that it lacks common sense. But suppose example, I'll take my fundus examination only. If there is any artifact in the fundus photography, it predicts n number of diseases other than saying it is an artifact. And whenever we see, the very first thing we say, it is an artifact. So, and this is one extreme. The other extreme is that when I get a it so happened that the fundus photograph was really very bad. It was a burnt out eye. Not exactly what the meaning of burnt out. It's an ophthalmological term, but it gives the answer as a normal eye. So extremities also the AI, it needs some more data, I think, for that to be corrected. Might be probably down the lane. These are all the things which it can give us, keeping the fact that if we give all the data properly from all the centers, medical health centers. And I wanted to tell one more point. Regarding the AI, it requires lot of clarity. I mean to say, if you take a photograph, it should have high resolution quality in order for that to deliver its report. But nowadays, yeah, technology is being moving very fast. 5G technology is being actually is great covering the areas, but it is limited to urban. It is not penetrating to the rural area. Until and unless that happens, these two things cannot be achieved for the real sense what we are looking for. So we request the policymakers or the government to see that this technology reaches, I mean to say, networking reaches to the every nook and corner of the country. And top of that, our medical field will definitely coordinate with whatever possible things we have. See that all this health facility will be reaching to the to very interiors of our places. And last and the least, last and most important thing is the legal and ethical aspects. I think whatever the problems which I am seeing, there is a talk on all these subjects. You will get clarity by all the eminent speakers. Sharing the data and preserving the data is very, very important thing. But frankly speaking, as a doctors, we don't know when and where and how the data is being breached. We just know how to collect the data and analyze it. But the legal aspect, we are least for that. And we don't know anything about it. So this is the area where the awareness has to be given to the doctors. How it can be breached, how it can be stored, and with whom it can be shared. We think that we take it very lightly. This is that after all data, we can share it to anybody. But there is a legal thing which is happening. You just cannot share any record of one patient with anybody else. Until and unless there are certain things, I am sure the coming eminent speakers will speak on that. So these are the few points which I wanted to mention. I will say that please sit, relax, and enjoy the eminent speakers who are sharing their experience for the all coming budding doctors. This will be the future, and I'm sure this will be a kind of foundation for you. Please take interest and enjoy all the lectures. Thank you so much for inviting me. Thank you.
Thank you, ma'am, for your thought-provoking words and support. May I request Dr. M.V. Sharma, sir, to hand over the token of gratitude to Radhika, ma'am.
May I request Mr. M.V. Sharma, sir, to present the token of gratitude to Dr. Jaya Geda, ma'am, in charge Dean, Professor, Department of Obstetrics and Gynecology, ESIC Medical College, Hyderabad. We now begin our scientific sessions, covering themes of telemedicine, AI, data protection, vascular care, and oral health. Telemedicine isn't just a tool, it's a way to augment clinical practice. It improves access and continuity of care, enables remote triage and follow ups, bridges urban rural gaps, and provides better documentation for medical legal safety. To give us a complete picture of this, we have with us our first speaker of the day, Professor Dr. Sadhana Sharma ma'am, Professor and ex-HOD of General Medicine, consultant physician and geriatrician with over 30 years of experience, ex-member of the Board of Studies at Dr. NTR University of Health Sciences, and an executive member of TSI Telangana. Ma'am will speak on telemedicine overview. Welcome, ma'am.
Change my slides. Yeah, sure. You want to use this? Yeah.
Good morning. Yeah. So I think before I begin, I would just say that ma'am said there's an eminent speaker. Today when I'm a passionate teacher, more than a physician and more. Now, I think my job has been made very easy by Dr. Rao, who has already told or given you some few lines about telemedicine. And then Madam, who has given a very good bird's eye view of the entire conference. I have made before I go ahead, I would just like to tell you that I have made my presentation combining the bird's eye view and a very vast 360-degree view. And for me, that was important because over the years, what I saw is somewhere we have lost the habit of reading our textbooks. We have started depending more on shortcuts. And when we started depending on shortcuts, that is where the whole problem arose. So ma'am just said that AI, she always found some problems with AI. I have embedded AI and I feel, yes, there are problems with AI. We have to evolve much more. Large language models have to come. We need a very good quality of data. But how do we give that data? That data has to be given by you. And for that, you got to know what you are doing properly. So we are a team. We are a team where we have healthcare professionals and we have the IT team. But who feeds the IT? It is we who feeds the IT. They are the ones who come up with the product which we want. So the data has to be absolutely good quality, and the good quality data will come once we as doctors, we start doing justice to what we are going to do. So as we know, I think it was early 1900s when the communication made a big revolution with radios coming into practice. So what we saw is that radios were there. They had invaded right from entertainment to defense systems. And then there was this fiction where we thought, could there be a doctor solving the patients of problems through radio? There were people who were thinking, so it is not just a phenomenon which has happened in 10 years, past 15 years, it was there. And let's see how it evolved. So if we see, today we consider Dr. J. Sanders as the father of telemedicine. He is a Harvard person. But as I just give you a brief, it's very interesting how it evolved. So 1900s, the radio came, and then it was in 1940 that in Pennsylvania, there was a transfer of information, that is images, between 24 miles between two towns. So we talk of email now, but the electronic transfer had happened then. Following that, in 1950s, what happened is there was this doctor, radiologist in Canada, who sent some images across in the two towns. So it has started then. And then in 1950, it was University of Nebraska, where the 2 TV sets were arranged in the campus and the medical information was exchanged between the students. And then came 1960s and 1970s when the US defense system, the NASA started using the telenetwork. So it has been there, and you see how it is evolving. Now, before we go, as Dr. Rao just mentioned, the whole idea of telemedicine is that you are reaching to the rural population. So our Honorable Prime Minister has started this ABDM. That is slide. This is not how the PowerPoint presentation is. Our whole departments which have started, medical education departments, which we say that how we should make the PowerPoint slides. There are rules for PowerPoint slides. This much should be the spacing. This much should be the spacing. This should be the font. I'd have deviated. The font. I'd have deviated. Because I feel that the old has to come back in some way. We have to combine both old and new. We can't negate old. We have to take certain things old. So like I said, you started depending more on the easy reckoners, the exam-oriented books. You started forgetting the old books which made you learn the subject concept-wise. And what was happening? So when we are not knowing the concept, we are treating only superficially. We have to take away the root. And for that, we need to know the subject at stretch. So I'm just focusing slides. Maybe you can consider it as reading hours. I'll be just telling you the salient things in this. So what is the help which gives us is distance, reducing the cost, accessibility, comfort, convenience for all the stakeholders, right features which can come when practicing telemedicine system. So there is a good public-private partnership now. So there's a lot of private people who came into it, jumped into it, in India also, following COVID. So COVID was actually a boon in disguise in some way or the other. Now what you see is that patient travels, most of the times, patient travels, he has come from this distance, so much traffic in Hyderabad. Forget the rural area. You just take a urban city like Hyderabad. You see, there's so much traffic. You are stuck in the traffic for 1 hour. You just leave you say this much petrol is going, this much diesel is going, this much time is going. Why? Why can't I have a consultation from the comforts from my home? It's not an emergency. So it reduces the healthcare cost. You see ESIC, madam is burdened. Our doctors are burdened here. Every patient of cough, cold is also coming here. And he is there putting a line in the OPD. So do we give the quality care? No, sometimes we just want to finish the OPDs. So it reduces the healthcare costs in hospitals. It reduces the healthcare costs for the person who is going to take the care. Better patient compliance, like I said, chronic health disease patient, they need not come for follow-up. You can do it. So they will not miss their drugs. They will not be going for complication. You have increased doctor-patient communication. You are having 200 OPD. 2 minutes, I have to finish the OPD. I have to go for surgery. I have to do that. What do? I have a telemedicine. I have my relaxed time. Patient has his relaxed time. Okay, let's have a very good communication with each other. So it builds a relationship. It's not that it doesn't build a relationship. Yes, we do have 5 sense organs. One of them is skin. The others are there. Tongue is there. Eyes are there. That can be used in telemedicine. You can give comfort. There is an enhanced doctor-doctor collaboration. In our times when we were practicing medicines, at that times what we had to do is I have to talk to somebody, call from some friend in Mumbai, and then I had to ask her, have you seen a case like this? What do we do in this? Now it's not like that. See, you can communicate. You have eSanjeevani, which is working here, or the private platforms. You have a choice. You have a choice of doctors available. So just think, my dear budding doctors, it's not just you. The Generation Z, you are the generation, the centennials, the silent generation, that is before 1945. Then came the baby boomers, they're the centennials, the millennials. You are the centennials. You have totally different requirements. You want Zepto, you want Blinkit. You don't want to go.
So healthcare is a hot commodity now. We want doctor at a click. That is what we are looking at. That is what the generation wants now. So even the elderly are adapting to it. So geriatrics is booming now. The old, like Dr. Rao said, villages are all empty. It's happening in urban areas also. There's so much of migration, in-city migration, outside migration. There's no caregiver. You are busy. The caregiver is busy doing his or her work. They can't take leave. So the old person is left behind. Doesn't telemedicine come to rescue? It does. For simple things, you don't have to bring the patient to the hospital, expose him to who is already immune suppressed, expose him to so many infections. No, it does work. And yes, as such, the system gets more efficient all over. So what we are thinking of is the chronic health measure, management, diabetes, epilepsy, hypertension, all these can be managed. You see the patient for the first time, then it can be managed very well through any modes of telemedicine. Throughout care, yes, continuous follow-up is there. You don't have to, and we worry. You see, I can read the psyche of a doctor also. I will not talk just from a very, charitable point of view. That every time is said the doctors are for charity, charity, charity. I do understand we are healers, we have to do charity, but we do have to pay our bills, we do have to pay our EMIs. I do understand this. We have to run our families. So monetary aspect is very important. So I see many of the young doctors, they'll be saying patients don't come for follow-up. No, they don't come for follow-up. You lose them for follow-up. This is very good way where you give, both the sides are happy, doctors as well as patient, when there is a continuous care. Prescription compliance, you see patient is following the health education advices, the lifestyle advices, the medicines which you have given. It is a job satisfaction, like Dr. Rao said. You don't know, you keep on thinking, oh, I diagnosed this, I started this medicine, but the patient didn't come back. What do I do? Your curiosity, that always takes you. So you have a job satisfaction. So you have there is a paraphernalia of things which are required for telemedicine. So the IT guys knows is more than so, but we do need their help. So you have communication technology unit, you have different, from patient size, you have the new technology advancements like wearable sensors and other things which I have mentioned. And then you got to have a remote medical server unit. Now, as Madam was just mentioning, there is always a hitch when comes that the two sides, they are compatible or not compatible. So you have to go for that. And of course, the medical professional unit, which comprises all the workforce as it is there in any hospital or any healthcare facility. So what are the different types of telemedicine? So we have this asynchronous telemedicine, that is store and forward. So that is predominantly like telepathology, teleradiology. So you have images, you have x-rays, you have CTs, you have MRIs, or you have some fundus pictures, skin, you have biopsy pictures, you have skin lesion pictures, which you can take and you can fax it, you can email it, and you can send it to the other person. But what happens in this asynchronicity? You are not being able to correlate. You are not being able to get the proper history. You are not being able to, you are just getting an indirect information, not a direct information. Now, again, one very important thing, Madam, in ophthalm is Dr. Natarajan. He has come up with, you can get the retina scanning done. So it is a something which can be operated even by the technicians, and they will just give the fundus, they will post the fundus images. So that is probably help in curbing the blindness all over the country so much. Then you have remote health monitoring. As I said, for chronic disease management, we know lifestyle diseases are on rise. Obesity, diabetes, hypertension, they are a pandemic now. So these were the diseases of the West. Thanks to us that we have adopted certain very bad things of West, where we have changed our lifestyle totally, and we are a victim to that now. So yes, we can do that. So we have a diabetic patient who comes to us. He is admitted for sugars, very high sugars. He comes for diabetic ketoacidosis. You have relieved him of diabetic ketoacidosis, and now you want to, still the diabetes is very brittle, it's not getting controlled. Now you are occupying an ICU bed for 15 days just for that. Is it justified? It is neither justified for you, nor it is justified for the country, nor it is justified for the hospital. It's not justified for the patient as well. There are people who have to stay there with him, leaving all their jobs aside. So what do? You can send them. You have these devices where you can be monitoring for arrhythmias, you can be monitoring for BP and sugars, and you can be in touch with them tomorrow. So yes, we can do very good remote health monitoring. Synchronous telemedicine, that is a real time or interactive, which is really very active right from the time of COVID, because I am into it. I entered it at the time of COVID with the multiple platforms, and I see, and that is when I got fascinated by it. You know, I thought it is really a wonder. I had my own suspicions, my own doubts. You know, how am I going to do justice? But no, I could do a lot of my examination through the video. I could do, and I could know which, this is for us to decide, you know, with your expertise, your experience, you know, what is it you want and what is this you want in this particular patient. So diabetes, what are the things I want to see? I want to see peripheral pulses, I'll call him to my hospital. I have to see that. But we are going to get sensors and analyzers probably where we get information about that also. So yes, so this is used for online consultations and diagnosis, and advantages, you get immediate feedback. So there are different kind of devices which can be used in telemedicine, right from sensors to IoT to audio, video, text, Skype, FaceTime, anything. Now, what are the 7 elements which we have to consider before going for telemedicine? So why is the context? Why is this telemedicine consult being taken? Now, again, it depends on you. Why? So a patient who has come with, say, just cough, cold or something, yes, you can do a telemedicine. But there is a person who is having some rash. What do you go? You go for a video consultation, or it is associated with something else. You want to look for lymph nodes. You want to look for a lot of other things. You're not going to go ahead with telemedicine. You are going to ask that patient to come in person and visit you. So you have to decide the context. So with private platforms, there are many private platforms of telemedicine. So they have a questionnaire, like Madam said. So you have some 7 questions, and patients get exhausted and fatigued filling that. And I have had multiple experiences where patients tell me, you know, they will write constipation present and giddiness present and everything. They'll put tick, 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 tick. And then when I talk to them, then I know the history is entirely different. Similarly, there are a lot of STDs where the patient doesn't want to discuss at all. So patients will be spending time, so they don't like it many other times. But most of the times, if we get used to it, we can do it. Identification of RMP and patient is very important. So we all know with the IMC Act of 1956, who is the registered medical practitioner, you know the definition of that, the person who is registered with the IMC register or the state medical council register. So he is an RMP. So when you are initiating a conversation, you should introduce yourself and you should confirm whether it is the right patient. Now again, there is an example. There used to be these companies. So that was way back in 2020 and 2021 when it had just begun. So a lot of these corporates, you know, they were there with these platforms. So what they used to do is they will take the consultation used to be for the mother or father or sister, but the identity of the patient would be the person who is working, because he wanted to save money. Now the onus lies on the doctor. So I had to confirm. So I see that the person who is speaking is a woman, or he says it is for my wife. So I said, no, I will not give this consult. I will not give the prescription on the IDs which have been entered. And I used to talk to the providers, the app guys who used to provide me with service, and I used to say, how do you do this? So, you know, over the years, they have taken all these data which has been taken, and they have refined to a large extent. Mode of communication, again, it depends on you, wherever it is available. It is ideally a video consult is always best for the first consultation, maybe for follow-ups and all, you can go for audio, text, or whatever it may be. Consent, we know, if the patient, so most of the apps are embedded, they take the consent from the patient and then the patient takes the consultation. But if you're starting in your clinic or this thing, if you want to initiate, then you got to have because there are no strict medico-legal, we are going to have a complete session on this after the talk. So we don't have, so we got to be very careful with the consent. So patient has to take consent from you, and that is called an explicit consent. Type of consultation, whether it is a first consultation or follow-up consultation. A first consultation is somebody who is seeing you, approaching you for the first time. Or within 6 months, he comes to you but with a different complaint. Or within a follow-up consult is somebody who has who has seen you once in person. It has to be in person, and then he follows you on telemedicine. So yes, you have to then evaluate according to your you have to be good, because telemedicine, it can really lead you in soup if you're not good with your subject. You have to know the subject. You have to evaluate, manage. There is no binding. There is just no binding that you have to prescribe the medicine. But yes, you got to have a provisional diagnosis, and you prescribe the medicines based on the provisional diagnosis. If you can't make a diagnosis, you always can give the option to the patient that you need a. If you can't give a diagnosis or you really need, then you ask the patient to take an in-person consultation. So this is how, what we have is patient details and entry will be there. Information input process is the telehealth support system. And then diagnosis treatment part is by us, that is the healthcare people. So you can give follow-ups, you need not schedule the consultation, just the text is enough. You have to see data documentation, data privacy, that is the most important thing. It is just not possible. Even now people are becoming aware. But I still remember that 10 years ago, 15 years ago, suddenly now India is also waking up. So it used to be that people are publishing, they are publishing things with the patient's whole face there, you know. Everybody's identity is important. We are all private people. We can't let anybody invade our privacy. So is the case with any patient. So how do we protect this privacy? And this privacy is protected by the telehealth support systems who take care of this thing, because we are not going to, and then identification, is the right patient or the wrong patient? Is it somebody who is just masquerading? So we have to see all that. Then you can easy prescription. 11 o'clock somebody has night, 10 o'clock a person takes consultation from me. Now we have 24-hour pharmacies, but are they accessible to your house? So they provide these facilities or giving e-prescriptions, and they have these pharmacies also which supply the medicines to your home. Yes, we get very good ratings. You would be seeing Google is all full over. You see everybody is trying to. That is how we have to go with the trend. Probably we have to be in time. So everybody says that you have 5-star ratings, 2-star ratings, and that is how patients find out. So these apps, they give through apps, patients' feedbacks. You can increase your practice as well. Facility of payments, real-time collaboration, because patient admitted in Ayush, then he is admitted in Yashoda, then he is admitted in ESI. And how do we do? So some records also. But when we have a centralized record system, it is very nice that the insurance problems can be solved, as well as we as doctors can arrive at a good solution for the patient. Madam just talk, I think AI, there is a session by Akhila already. AI can assist. Madam, I agree with Madam completely and thoroughly that AI cannot replace, it can only be an assistant tool. And AI again has to be used judicially. How good is the data is what is going to determine our AI things. And as I said, you are the guys, if you use AIs, you have to be giving good data. For that, you have to know your subject properly. Yeah, so clinical applications, as I said, it is for teleconsultation. Lot of anxiety, depression, mood disorders, mental health is a ruckus now. Everywhere we are listening only to mental health. We don't want, you don't want to accept, see the doctors. It's not any educated person, it is still a taboo. It's still a taboo whether we agree or not agree. You will not like to go in person to a doctor or a mental health specialist and say, I am having such and such problem. So it is the best. It is the best. Way back, that is, I'm talking about late 1980s. That time I was just in my high school, and there was a very good article in the Hindu where they had published a study where they said out of 10 people, 1 person has a mental health disease. And if you read a psychiatry chapter in medicine, the psychiatry section, actually I feel I also have some disorder. So you know that is how it is. So you start. So there are a lot of things which are there, and people, especially for mental health counseling, it is very good. Anxiety and depression, where your identity is totally, it is your choice. You want a video, you have a video. You want an audio, you have an audio. STDs, again, it is your choice. So I get many patients from Mumbai. So there are many commercial sex workers. All of them, youngsters indulging in Generation Z is very, very nice. I love Generation Z. People, I don't know why people are all about Generation Z, but they have got lot of positive things. They really motivate me. But then Generation Z is experimental. It is very curious. It experiments in lot of other things which were not conventional. And then they suffer, they have problems, and then they come to me. So I have been handling lots of things, and it really works wonders for them. Telepathology, as madam said, we can really get good size. You don't have to go to Bombay. I think with all Om Shanti to Dr. Anita Burgess. She is a renowned oncopathologist who expired. And I think all of us used to send to Dr. Anita Burgess or to Dr. Roshni Chenoy and Tata Memorial if you want a second opinion, third opinion. You have to go, you have to seal it, get the slides, seal it, send into Tata and then get it back. No, telepathology is working wonders, and similarly is the teleradiology, telecardiology, teledermatology, I mentioned remote patient monitoring, home medical care, emergency care support. Very important. There has been an accident, right? So you don't know. So most important trauma, somebody has had an accident, vehicular accident. What is it? You want to stabilize the spine. These people don't know. You will tell them that you keep the neck in the proper position. CPRs, yes, you have done your basic training in BLS. You can guide them how to do it. 12 o'clock night, somebody is calling you, patient is unconscious, not responding. He has a sensor, or they are smart enough now, patients. They are very smart. They will say, we can't feel the pulse. They will have BP measuring machines. They will say, we are not hearing anything. They will just put the can, there is no heart sounds. You can tell them how to do a CPR as well. So emergency, it works. Now, what are the practical applications? So remote consultations, our whole idea everywhere was to reach to the rural area. So simple viral, simple throat pain, pharyngitis, you need not visit the hospitals. You have to go to, it helps us specialists. You want a cross consultation with a pulmonologist, with a nephrologist, all of us can meet online. Remote surgery, robotics coming in big way. But yes, as madam said, it has to be accessible, it has to be reachable, and it has to be affordable. Let's wait, the day might come soon. Pediatrics, CBTs. Pediatrics, most of the times they have to be in person, but CBTs can be done very nicely on the pediatrics. And yes, crisis. We have seen COVID. COVID was the biggest eye-openers. You see, right in the Afghanistan war, the Iraq war, the Bosnia, US had been using it for long. ISRO had used it. ISRO had used it long. ISRO in Trivandrum had used it for defense services. So, in fact, Gwalior Medical College was in India had started telemedicine long back. SGPGI had started. It had started connected to the. They are actually going to start. I think department also totally. The course they are going to start probably. So yes, in military crisis, disasters, natural calamities, it works wonders. Now, I'm not going into the details of guidelines, so because what I see, I thought that I would be having a mixed crowd of residents as well. But what I see is mostly undergraduates. So once you start practicing, these all guidelines are available on the net. You can access it. But how did it start? So it was in 2018. 2018 when there was a doctor couple who had advice. So there was this postnatal lady who had gone home and he had continuous recurrent vomiting. So she called the doctor. The doctor didn't ask her to visit the nursing home. And it was the nurse, she told some injection to be given by the nurse to the patient. The patient died. That is when the entire controversy erupted. That is when the Ministry of Health and Family Welfare started thinking, how do we do about it? Because there are certain, even now, for data privacy, HIPAA guidelines and all are there. They are in US, you have Europe guidelines. We got to have our own. So it is then that they woke up and then they said, okay, we are not really going to have a, legal, a proper legislative guidelines, but we'll have some guidelines for practicing telemedicine, and that was in March 2020. So that was drafted by our medical council itself. It is available on the net. You can all go and have a look at it. So that will give you an entire idea of how to go about it, how to go with the tensor. I'm not going to repeat that again. So yes, and one very important point in this is, again, if you remember, if any of you remember Sushant Singh Rajput, do you? Yeah? So you remember there was a lot of controversy about how he died. Yeah, it was a suicide. What was it? So you know what was the problem? The problem was his doctor friend or the physician whom he was regularly visiting. He had taken, the doctor had advised him to take clonazepam because he was feeling restless and he was not getting sleep. So he had taken clonazepam over the counter. Now we don't know. So we have this, we all know that there is a 1945 Narcotics Drug Act where there is a Schedule 10 which says that there are certain medicines which cannot be given by prescription. Right, because they are habit forming, like amphetamines, ketamine, and all these are habit forming, the drugs which can be abused. So telemedicine, you cannot prescribe these drugs. So there is a different group. So they have a O list of drugs, which is over the counter, paracetamol, vitamins, lozenges, supplements. Yes, you can give it. Then there is a group of drugs. A group of drugs, you have seen the patient. Patient is on antidiabetics, antihypertensive. Sorry, Akila, am I exceeding? How much time? 5 more minutes? That's all. Thank you. So I think I still continue to take it as a teaching session rather than a speaker, because I see only the student cried, and it is, they are the ones who are going to determine, not the machines. So yes. So yeah. So you have this A group, the B group, and O group, right? So we have these different techniques, which if you are interested, you can always read. It's very fascinating how we can, store our data and how we can have a data privacy as well. Yeah. So what are the pros of this telemedicine? Pros, as I said, there is a seamless transfer of medicines. There is no wastage of time at all. Everything happens fast, quick. It is like Blinkit, Zepto, everything. Enhanced patient management. You do. You have seen the patient for once in your physical consultation, and then follow-ups are there, and you are the patient is being taken care of very well, and you are satisfied. It bridges the urban-rural divide. Now I am going to my last slide is going to focus on how in India has it practically transformed the rural lives. Operational and clinical efficacy, yes, we know that, you don't have waiting time, you don't have to travel. Pandemic infection control, COVID was the biggest example. I remember COVID was a time when I used to have almost 30 consultations in a day, 30, 35. I used to be monitoring, I used to be looking everything, and that was, it was, people were in Delhi, they were in Mumbai, they were everywhere, and it was so satisfying for me, when I was thinking that, yes, there are so many people who are saved this business of entering the ICUs. And the most important is the national initiative of eSanjeevani, where the ESI is one of that. And initially it started with, the medical colleges, then it expanded into the government hospitals. What are the cons? Yes, clinical limitations. You don't have physical examination, but whatever is available, you can do it depending on the patient's history, depending on what you frame in the mind after listening to the patient. But where you feel, no, my stat has to be used, there are innovations going on. We are going to get digital stats. We are going to get lot of things where the patients can tell us. There are apps which can read the heart, which can tell us about the heart sounds, the abnormal sounds, everything. All these are going to be embedded. It is there. It's a dream, but it is there. And yes, you need a good training for all your staff, and technological barriers. Very much important. How is the connectivity of your internet services? Privacy and security concerns, still a very valid concern. And insurance. Again, insurance parties, they have their own rules, they have their own regulations. They will reimburse telemedicine. They will not, only for these diseases, not these diseases. So that is a big mess which has to be sorted out. And yes, as we mentioned, rural and urban barriers are always there regarding how much is the digital seepage into the far remotest corners of this country. Now this is the study which I was talking about. So if you see this, who is using telemedicine now? So we see younger and tech savvy doctors who are adopting this technology. But believe me, I don't consider myself old. I don't consider myself young. I am in the mid this thing, right? But it is wonderful. It is a feast. Good, But yes, feast also has some limitations. So we know what we have to eat and what we have to discard. So, and you see, we were talking about equity of the healthcare. That is what we were trying to achieve. That is our Prime Minister's vision, equity of healthcare, because nobody is migrating. So you don't want to, I do understand from your perspective, you don't want to go to your village again, where there are no proper school facilities, where there is nothing. You want a better, better future for your prospective generations. You don't want to go back to the place where you originated. I do understand it. So how do we overcome this barrier? Telemedicine is going to overcome that, but still this study shows that it was only 80% was from metropolitan or urban centers. I get from different places, but sometimes I get from as far as Jharkhand also. And it is used across public and private sectors. So that the public sector, the biggest example is our eSanjeevani. And if you, this is smartphone is something which people use most of the times, and then the laptops. So coming to just to wind up the entire thing, 85% of the doctors, mostly the young doctors, they are aware of telemedicine guidelines, and 80% agree that the guidelines have strengthened practice, but 20% is still there. So most of the ethical and considerations as it goes with our in-person practice, it goes with this also. So that hitch is still there. So for that, that confidence has to be there that when you are practicing with telemedicine, you don't land yourself in a medico-legal trouble. Key incentive is reduce teleconsultation fee for patients. Now this is a question mark. This is a question mark for everybody because this is what you want and what I want. So it is from each individual's perspective. You want to keep your consultation fee as 1,000 or you want to keep your consultation fees as 100. That is you. That is with what you have come, what your goals are. So you remember the quote of Neil Armstrong. Anyone remembers? When he stepped first on the moon. Remember? One step on the moon and a giant leap for mankind. So there is a small step for technology and a giant leap for healthcare. So what I would say is your generation is a fantastic generation, very good generation. It is very curious. It loves experimenting. It's very open. And you believe in dating. Dating, you explore the dating apps. You are most of the students, they don't want to go the conventional way of marriage system. How can you live with a person whom you have not known at all? So you are into trial and error. I'm not generalizing. I'm not saying the whole Generation Z, but you are. Nothing wrong with it. I did it 25 years ago.
Thank you, ma'am, for explaining how telemedicine augments clinical practice, improves access and continuity of care, and bridges urban-rural gaps. Any questions from audience? Anyone? Anyone?
Good morning, all. Thank you, ma'am. That was a fantastic talk. I just want to understand, is there any specific body from the government side or in collaboration with the private sector that is trying to devise policy guidelines or keep updating the policy guidelines? Because we see in 2020 March, which was amidst the COVID, telemedicine guidelines have come. But since then, there is a lot of technology shift, and especially with regards to AI. So is there any body that is devising policies or guidelines for the AI adaptation into the telemedicine?
Yeah, very good question. So as you are a doctor?
Yeah, I am Dr. Raju, and
so you're from healthcare?
I know healthcare. I know a bit technology also.
Oh, very nice.
I'm an alumnus from ESI. I was here as an assistant professor 2 years ago.
Okay.
Presently associated with a private hospital.
Oh, thank you. Thank you, Dr. Raju. I think, yeah, what you say is very correct. So after 2020, we have not got any updates. And so this is still a big gray area, even embedding AI. That's the reason we say that when you are, so it is, some things are there, like the guidelines which have specified from 2020, and they stand still now also. That is how we do in our our in-person consultations. You got to diagnose, there should not be negligence. Some basic things should not be ignored. So, and no, so that's what I was saying. So it had been the Ministry of Health and Family Welfare had given it only to the MCI, that is the NMC, which had framed the guidelines. Now the IT is accompanying, and I think the lawyer here, whether she has something more to add apart from data privacy. As of now, I am not aware that anything like that is coming. So that is the reason, because AI itself is, I will not say, it is still in a toddler stage. See, I attended one, I am going through a course of AI and ML. Okay, and in that we were having regular discussions, and there they were giving some activities. So in the activities they were giving, so that they are the very basic AIs. So they were giving like a case scenario where the patient comes, patient has fever, cough, sputum for 4 days. A patient is a diabetic. They don't give any vitals, and then chest X-ray shows bilateral infiltrates, and the diagnosis by AI given is severe CAP. And the treatment advice is a 3rd generation cephalosporin with a macrolide. Okay. For me, that is, do you think it is enough for you? Somebody who is 55, do you think with this information, you can just start with you can label it as severe CAP, where you don't have even the vitals, where you don't have, patient is a diabetic, he must be having heart disease. Why? How do I say whether it is infective, it is non-infective? How do I say it is severe? I don't have any score. So yes, so I say it is a data. So data is the thing. So unless and until we reach that stage, I think abroad also, wherever they are practicing, there are still, I am not aware if there is any legislation which has improved, which has involved the IT people also. But one thing which is there is regarding data. So you have given, as you are correct from your treatment point, from your diagnosis and treatment, if there is a breach of data privacy, or if something happens from the third party, then they are responsible. But from medical point of view, you are only responsible. And as of now, apart from that 2020 guidelines, nothing is there.
May I request Dr. Karunakar sir, founder of Swashodhan Trust, to hand over the token of gratitude to Professor Dr. Sadhna Sharma ma'am. Great ideas often begin small, sometimes as simple observation or student projects.
Yes, and today's poster display is proof that the next generation of healthcare innovations is already here. We would like to inform you that the poster presentation will be running parallelly on the first floor.
These posters represent the creativity and hard work of our participants, and we look forward to recognizing the best of them during the award distribution later today.
We encourage everyone to explore the posters and engage with the presenters during the networking time. I request the poster presenters to please proceed to the first floor. So our next speaker of the day is Dr. Rahul Lakshmi Narayan sir, consultant vascular and endovascular surgeon, and consultant podiatric surgeon at Medicover Hospitals, Hyderabad. With over 10 years of experience, he is highly skilled in managing peripheral arterial disease, aneurysms, venous diseases, and diabetic foot care. He holds qualifications including MBBS, MS, DNB, MRCS England, and MCH. He is well recognized for combining advanced surgical techniques with preventive vascular health care. Sir will speak on the relevance of AI in modern vascular imaging and intervention. Welcome, sir.
See this? No, it's not there. Just give me a moment.
Bring my laptop.
Yeah, sure, sure. Sorry? Yeah, got it.
Good morning to one and all. I'm Dr. Rahul Lakshminarayanan. I'm working as a consultant vascular and endovascular surgeon at Medicover Hospitals, High-Tech City. So the topic that I've come to discuss with you all today is the clinical application of a very loaded and a very complicated term called artificial intelligence. I think subsequent speakers will be elaborating further on the complexities, the subfields of them, of artificial intelligence, how they work, and how they may be applied. I've just touched on this basic aspects of them, and just to show you where, how far it has progressed, and the current application in the field that I practice in. So the general way that artificial intelligence works is there are many fields, there are many subfields to this as well. It is the use of machine algorithms to look at large subfields of data, to basically assist the physician's work rather than replace the physician's work. And every field where artificial intelligence is coming in has seen applications. There is ongoing research. So we are not even midway. We are just about where the starting point of where artificial intelligence can be applied within the field of work. So in the course of this talk, I'd like to talk in the following subheadings. We'll be talking about a basic introduction, how the subfields of artificial intelligence are, then how this can be used within the fields of medical science and the current evidence which is there and the current research body which is there, where in individual cases, especially in terms of vascular surgery and vascular interventions and imaging, there is evidence where it has shown to help. And of course, in the course of the same talk, we'll talk about future avenues of the same. So artificial intelligence is loosely defined as the study of algorithms that provide machines the ability to reason, perform cognitive functions, such as problem solving, object and word recognition, and decision making. Of course, one follows through to the other, and the overall applications in medicine involve looking at large amounts of data, which if you were to look at them manually would be significantly time consuming, would be fatiguing for the medical professions, would need a large team. And of course, there is a tendency to miss things out, which a machine may not. But these also need, when you use machine algorithms or program algorithms to look at large amounts of data, they need to learn how to recognize patterns. And once they do learn how to recognize patterns, then it follows through that they'll be able to predict outcomes, looking at a large existing body of information which already exists. And once it has reached this third stage, then it may aid in drawing conclusions and improving workflows. So as you can see, it's a stepwise process. And in different fields, it will be at different stages of evolution as it goes forward. So I'm sure anyone who has even superficially read about artificial intelligence would have looked at these various subheadings. And I'll be touching on some parts of them. But to simplify them, they are all interconnected and they're all involving the use of multiple algorithms and computer programs which work together. On a simpler basis, basically, the machine learning involves creating multiple programs which are trained and programmed to look at different raw subsets of data. And then while we train them, of course, there are different kinds of machine learning which are there, which are supervised and unsupervised, which I'll be coming to shortly. When a machine learning has understood how to work with a certain groups of data and how to recognize and analyze them, then what ends up being created is what is displayed over here, which is a neural network. So a neural network involves multiple nodes. Each of these shapes, as you can see, are nodes. So whenever any amount of information is inputted into a particular program, it is processed and it is forwarded to multiple subsequent nodes. Then each of these nodes have something called a threshold and a shutdown limit. And if in case it reaches the threshold, it gets pushed over to the next series of networks. And when all of these nodes interact at multiple different levels, what we get is an output at the end. Now, to simplify what all of these are is machine learning is a subset of artificial intelligence, and neural networks and deep neural networks are a subset within machine learning. So once you create a certain number of sophisticated programs, they end up being incorporated together to form a network. When more than three such layers, if you can see, there's multiple columns over here. So if more than three such layers exist, it's called a deep neural network. Otherwise, it's called an artificial neural network. This is a very simple overview just for everyone to understand it at an undergraduate level, as well as the more people who are already well versed with the topic. Once you have artificial neural networks or deep neural networks, these can be used for either speech, natural language processing, which can recognize either written or spoken word, and even computer vision. Means that the computer itself can look at images, videos, medical imaging, CTs, MRIs, and various more complicated forms of study, and using the information that already exists within its programming, use the raw data to come to newer conclusions. So all those four aspects of artificial intelligence have been studied in the course of vascular imaging and study to guide decision making in overall medical therapeutics. So as I mentioned, so machine learning enables machines to learn and make predictions by recognizing patterns. So what I had mentioned as supervised and unsupervised simply involves the presence of machine learning programs with the assistance of either someone who is guiding the program. So if they need to identify in a CT study, for example, if they need to identify what an aorta looks like, it has to be labeled beforehand by a technician or a radiologist for the computer program to understand that, all right, this is the aorta. And once I know what the aorta is, then I can calculate the size and make any conclusions regarding what it may look at. So when there is someone who is assisting the machine learning program to look at the data, it's called supervised learning. Once a significant amount of supervised learning has happened, then unsupervised learning can happen, where now a trained program is exposed to large amounts of raw data, and unsupervised learning then looks at patterns within this data. All right. Both can work together looking at data, and both will be helpful in coming to conclusions regarding the data. And what is important here is that it may find a lot of subtle patterns which manually, if you are trying to look at, you may only find it occasionally, or you may really need to be very thorough with the data to come to conclusions to. But when you're applying an algorithm or a program to this, it may be able to look at subtle patterns which would not otherwise be visible. So natural language, it may seem like a lot of words together, but it's something we all use. In fact, the Google search algorithm that we use on our phones itself is a form of natural language processing, which is used regularly daily, and it's already in application. So the Google program itself is able to give results in seconds because it uses machine learning and artificial neural networks to assess what we enter and come to results based on that. So successful natural language processing programs must expand beyond simple word recognition and look at multiple other forms of speech and syntax. And the medical application of natural language processing involves if, for example, we are taking notes or we're dictating notes after concluding rounds. So if we record all of it into, for example, a microphone, and it gets transcribed into a set of notes, it's a way of looking at a large amount of data, simplifying it and documenting it, saving physician time and making decision making more orderly and faster. I'd already touched on artificial neural networks. So artificial neural networks are basically a combination of multiple such programs which work together. And deep learning networks are when 3 or more layers of artificial neural networks come together to look at more complex patterns. And computer vision describes the machine analysis of images and videos. So there are significant advances that have come up in to enable machines to look at different kinds of videos, and vision looks at higher level concepts. So looking at multiple patient cohorts, longitudinal studies over the past several years. So a lot of existing data to incorporate a natural history of the disease progression. And once there is a significant body of data, these can be used to look at patient's present condition, present aortic size and disease, and to predict a potential disease progression. And as I'll describe, there is already a good program which has come up and has been in use in the European Union called Vasculate, which I'll be describing again shortly. So in my field, which is predominantly a clinical field without much of direct application of AI right now, but there is a tremendous focus going forward. So the main point of artificial intelligence is to look for disease prognostication and prediction. So when vascular surgeons generally deal with diseases, it involves a lot of either diseased vessels which can become swollen and aneurysmal, and if they do rupture, it can be life-threatening. Or it can involve multiple blockages in either the leg circulation, which is called peripheral arterial disease. Even the significant stenosis in the blood circulation towards the brain can lead to strokes. So all of this is heavily image-based along with the clinical background. We incorporate both the clinical history and the clinical background of a patient with the latest imaging technology to come to a potential therapeutic option for a patient. And often a patient will ask me that, what is the likelihood if I don't treat this disease? Or what is the outcome that I can expect? Will I be saved at the end of this procedure? And these are difficult diseases. So these are difficult questions which are difficult to answer because we try to look at all of the data, all of the research regarding this. But even despite all of the data that exists and a lot of the scoring patterns which exist, it is difficult to always predict how some outcomes will go ahead. The well-studied field in vascular imaging and study is the study of aortic aneurysms. So in this, the problems that we end up encountering with aortic aneurysms are, there have been studies, many well described studies and assessed studies through peer-reviewed papers which show any aortic aneurysms which are larger than the size of 5.5 centimeters need to be treated either with open surgery or with endovascular surgery. So the diagram here shows the endovascular stent placement to treat an aortic aneurysm. But a patient who comes with a smaller aneurysm, we are unable to accurately predict the growth rate, and these things may vary based on the presence of hypertension, smoking. For female patients, the same size of 5.5 centimeters is not well applicable. So a smaller aortic aneurysm size will need to be treated. Along with this, the anatomical configurations itself. So the amount of wall stress and tension will also predict the outcome. The amount of intraluminal thrombus will also predict. So these are all a lot of technical terms that I deal with regularly, but these are all issues which complicate the question as to, suppose someone has a smaller aneurysm. Is it likely to rupture within a year, 2? What is the longevity and how do we predict this? So this is just to show what happens when an aneurysm slowly develops, and that it can rupture at any point of time once it reaches a certain size. And the outcome, once we treat it, how the aortic aneurysm will respond once we do treat it with either a stent or a surgery. So there have been one machine learning study has been done, which was done in association with the Oxford abdominal aortic aneurysm study. This showed that overall, looking at the abdominal aortic aneurysms over a 12 to 24 month period, it was able to assess the growth of the aneurysm up to within a 2 millimeter error. So simply put, to explain to you. A patient comes with a 30 millimeter size or a 3 centimeter size aneurysm. A rapid growth of 1 centimeter within a year requires a surgery, which means that the patient is likely to have a rapid growth of the aneurysm, which needs to be treated. So when you're looking at such a mainly a threshold of a 10 millimeter aneurysm growth, a 2 millimeter error is not very significant. It is significantly effective in predicting to us that what the likelihood of the disease progression is. So this machine learning technique had looked at pre-existing data, the pre-existing papers of close to around 18,000 patients who had already been treated or conservatively managed, looked at the disease progression and were able to look prospectively to predict whether the patient was likely to have an increased, how much the aorta was likely to increase in size or not. Similarly, the studies have also been done which looked at outcome of the aneurysmal size. So whether it was the endovascular stent, once it was placed, how the aneurysm was likely to respond to it, and over follow-up, how the endografts were likely to sit within the aneurysms. We are to look at mainly in the future after an EVAR stent graft deployment, which is an endovascular aneurysm repair, what the outcomes were and the likelihood of further treatments, further stent placements for any complications like stenosis, narrowing, or what we call an endo leak. Similarly, for peripheral arterial disease, so this is one of my own patients who I've had to do a bypass for. So when we do get a major block in the vessel, we do need to do a bypass for a patient, especially when there is significant critical ischemia at the lower limb. So there have been studies which looked at a lot of patients, both peripheral arterial disease patients as well as normal patients through general ward rounds, looking only at the electronic medical records. And a study had shown that this was able to successfully predict the incidence of peripheral arterial disease in a patient purely looking at electronic medical records, not even looking at clinical data of the direct patient-to-patient feedback from a trained doctor, but looking at existing medical records to predict the incidence of peripheral arterial disease. And there was a higher positive prediction of peripheral arterial disease compared to a standard ICD coding in this study. Similarly, for cerebral vascular disease, there are no studies right now existing for the current status of cerebral vascular disease here. But in general guidelines at present, we treat either with stenting or with endarterectomy any patient who has a more than a 70% carotid stenosis. So the AI models are already looking at whether they can improve the quantification of the stenosis and looking at the natural history. So if a patient is likely to develop a stroke going forward. And the future here lies in using AI to assess the MRIs, CT scans, as well as ultrasound imaging to assess how close we are to the existing imaging guidelines and to predict for future stroke risks. Other future applications include looking at imaging analysis and vascular diagnostics overall. So a particular study, I had actually, because I was interested in this about 6 months back, I had discussed with one of the IT firms in Hyderabad itself. And they have actually been in touch with Narayana Hrudayalaya in Bangalore. And already they have created a pilot study looking at simplifying cardiac MRIs for them. So a cardiac MRI is a study which takes at least 30 to 40 minutes from the radiologist side itself to look at a lot of different cuts, a lot of different studies to look at the ejection fraction and to predict multiple features which are needed for the cardiologist to predict cardiac health for patients who are not suitable for any other studies. So using AI, they were able to bring this analysis time down to about 10 minutes and assist saving time for the radiologist. To keep it in mind, it's that whenever we use artificial intelligence, it's not to replace what a physician does. It's mainly to assist, make their life easier, and assist in more accurate decision making. So apart from that, it also is able to predict, as I mentioned, for peripheral arterial disease, for aortic aneurysms, looking at imaging studies and assess the operative planning or to help with overall long-term follow-up. There is a significant role for artificial intelligence in the term of education itself. So looking at virtual tutors, robots, or virtual reality simulations, existing data or anatomical studies, even imaging studies can be converted into models or even virtual images to assist in training for residents. It can help even with surgical trainees to identify patterns and predictive factors to assess regarding a patient, trainee's surgical tendencies, any potential mistakes, or any feedback which may need to be given. And of course, it can be used as an objective tool to assess how a trainee is doing over a period of time and to assess the competence of health professionals as well. There have been other studies which have looked at, this is already an existing perioperative risk stratification program which exists called My Surgery Risk. And this has shown a significant correlation with, in fact, it has shown a better overall surgical outcome predictor in terms of overall complications. Which was better in all other aspects compared to the physician who was treating a patient, except in overall cardiovascular risk. So to put it in simpler terms, when a patient goes in for surgery, every potential surgery has multiple complications which can happen. So when these surgeries do happen, what the study showed is that a physician is able, or a surgeon is able to predict what the likelihood of cardiac events are following the procedure. But there were many other complications where they were not always able to predict the overall outcome or the risk of complications, which in this situation with this program, it was able to predict more accurately. And finally, coming to the study where I had mentioned earlier. So this is a video which is already there on the Vasculate website. So I'll just show you what they have been able to achieve till now.
I'm Kake Young, vascular surgeon in MCMC, the Netherlands. The Vasculate platform uses AI to predict cardiovascular disease progression in AAA and PAD patients. The Vasculate consortium consists of 14 partners all over Europe. We collect all kinds of data, including genomics, proteomics, and medical imaging, but also from our patients themselves, including heart rate and physical activity. To predict cardiovascular disease progression in AAA and PAD all over Europe. We collect all kinds of data, including genomics, proteomics, and medical imaging, but also from our patients themselves, including heart rate and physical activity. We want to personalize prevention strategies and predict low and high risk patients. AI is used in an app to collect data from the patients and also automatically segment the peripheral arterial tree and a AAA with also blood flow simulation within only seconds. We have developed an ethical and legal framework where we analyze the requirements for trustworthy AI. In December 2024, we have our first prediction algorithms based on a retrospective data collection in over 11,000 patients. And we expect the first inclusions in our prospective study where we validate our algorithms as well. Thank you for your attention, and you can find more information on our website.
So this is a particular talk which I had actually witnessed in New York 2 years back. And the surgeon is carrying out a prospective study which is ongoing, and the results of that are likely to be coming through. But there has been daily assessments, daily data sharing, yearly data sharing meetings do occur, and they have already an existing app which looks at overall aortic health, aortic aneurysmal progression, as well as prediction patterns for peripheral artery disease, which I had already mentioned. That brings me to the end of my talk. I look forward to any questions from the floor as well.
Thank you, sir, for that eye-opening session on how AI is revolutionizing vascular imaging and intervention. Now may I request Mr. M.V. Sharma, sir, to hand over the token of gratitude to Dr. Rahul Lakshmi Narayan, sir. Any questions from audience? Anyone? So just a quick reminder for the speakers to keep an eye on the clock so we stay within the time limits. Artificial intelligence in healthcare is often seen as futuristic, but it's already here. AI supports clinical decision making improves workflow efficiency in areas like triage, imaging, and documentation. But it also raises important questions of validation, bias, safety, and governance. Helping us demystify this balance is our next speaker, Dr. Akhila Kochru ma'am, co-founder and CEO of Oxidius Health and Secretary of TSI Telangana. With 14 years of experience as a physician, data scientist, and project manager, she has previously led clinical governance and research at Apollo Hospital's Telemedicine division. Ma'am will speak on demystifying AI in healthcare. Welcome, ma'am.
Hi everyone. How's the energy in the room? You guys are enjoying the session? I've been sitting here and all my ears loved the sessions that were going on so far. And I think you all have taken some valuable insights from this because it would take very extra effort for us to bring all these speakers here for you and present these informative sessions for you. So now let's proceed for the session on demystifying artificial intelligence in healthcare. So I'm Dr. Akhila. I'm CEO and co-founder of Oxidius Health Technologies. Oxidius stands for Augmented Clinical Decision Support System. And that's what my startup is, which is 2.5 years old. So let us start with one question. What is artificial intelligence? Some students answered as artificial intelligence is AI. Some said artificial intelligence is ChatGPT. How many of you agree that artificial intelligence is equal to ChatGPT? Can I see a raise of hands? I think we have got very beautiful insights in terms of actual implementation of telemedicine and artificial intelligence in different specialties, particularly in rarest of the specialties that we have seen, which is vascular surgery, that the previous speaker has spoken about. So we'll try to gather our attention on the Indian context that we all are working in. So first of all, India is very famous nowadays because of its population. So we have 1.4 billion people. And how many doctors to serve them? In urban areas, we have one doctor for 1,456 patients. And for 10,926 patients, we have one doctor in rural areas. That's the actual reality. So for anyone who has the question of will AI replace the medical expertise, here is your answer. It cannot replace the expertise because there is a humongous need in terms of the healthcare services requirement in the society. There are 5.2 million deaths happening annually. And why are these deaths happening? Now there is a one critical observation that third most leading cause of death in developed countries is medical errors. What are medical errors? Medical errors can just be a missed diagnosis, a missed medication. You have prescribed something which have a contraindication to the patient. You have forgot giving any supplement or any additional medication. So all these forms of care gaps can eventually contribute to medical errors. If there is significant enough, it can cause the life of the patient to be lost, which is a huge loss for the family. And what can it do for the medical fraternity? It could cause our license. There has been a lot of cases. I'm sure our next speaker, who is a lawyer by profession, would be throwing some light on the number of specific for Indian healthcare context. Are these all avoidable? To a great extent, these are all avoidable. 50% of care gaps, it is said by a report generated by European Commission that 50% of the care gaps can be reduced or mitigated by implementing a simple thing called evidence-based medical practice. What is evidence-based medical practice? It is not just following the textbook. It is a harmony between three things. One is the research evidence which comes from the medical literature. The second is the clinical expertise that a doctor develops over a period of time. And the third is patient values. By bringing a harmony between these three and making the millions of decisions for the patients, we will be able to practice evidence-based medical practice better and avoid the gaps that are occurring. But this is not happening very rampantly, and with many of the doctors that we have spoken, most of them might not even know the term, what it means. What is evidence-based medical practice? It looks like a very distant entity now. And there is a very valid reason for that as well. The reason is the concepts have been designed for resource-rich settings, which is not the scenario in India. And the ground reality in India is always very different. The ground reality is that in a day, in a PHC, a doctor might have to deal with around 50 to 100 cases in a day. Now, will the same energy be with the doctor when he's dealing with the first case and let us assume a 70th case probably in the day? Will there be the same attention for each of the medical detail that the patient is providing? Will the attention and energy be the same to process the years of expertise that they have built in and have balanced that cognitive load and ultimately arrive at the decision at the point of care? Might not be there. Today, when we started our session at 9:30 and it is 12 o'clock now, and we are already seeing, less energy in this room. Imagine the pride that the doctors might be going through in these rural healthcare settings. So there are a lot of gaps in terms of the human capability when they are stretched beyond the limits. Now, what is the importance of human intelligence and human being or a doctor being in the picture? Most importantly, if we just talk to the patient, 90% of their actual health condition, if we really listen to the patient, 90% of their suffering would be lost. That is a very age-old belief. Now, the human touch, the empathy and the connection is irreplaceable. But the brutal truth that we have to accept is that humans are prone to fatigue, cognitive load, and information saturation. And a human mind, this is a fact that I'm quoting here, can retain 2 million medical facts. And how quickly medical science advances, it advances every 73 days. So how quickly will we be able to update ourselves and keep ourselves up to date? Now, where does artificial intelligence shine? First of all, it does not have the fatigue that we humans might have to go through. The second thing is the compute. Now, when was artificial intelligence actually introduced? Is this a recent concept? To process humongous information in just milliseconds, and consistency, which is no cognitive bias, fatigue and bias drift. And there are very good use cases. I would not spend much time on that because the previous speakers have spoken about it. There are good uses in radiology, pathology, and drug discovery, where many doctors today, it's basically the tech giants are claiming that now we have medical intelligence that the doctors can be replaced, because of which this entire stigma is being created that AI has the power to replace the doctor. But in fact, it is not, and we will understand eventually about it. In Indian specific healthcare scenario, at one point of time, challenges were that there were paper trails, there was very less visibility and data continuity, processes were entirely manual, and it was prone to huge diagnostic errors, which, mind you, were not coming out because these are not documented most of the time at one point of time. Today, although we have a lot of data about talking about medical errors, it is again only captured with the few of the actual digitization that has really happened. And today the challenges are because of too much of maturity of the systems, we have administrative load. The electronic medical records that are currently available today are actually causing burden to the doctor because of there is too much of typing that is involved, where again artificial intelligence can play a significant role. And today there is a burnout also experienced by the doctors because of too much of data, and evidence gap has also unfortunately significantly raised during this time. The critical gap of artificial intelligence for Indian healthcare scenario, like our Dr. Radhika ma'am has mentioned, very important point, the data on which the AI today is trained. All the foundational models like the models run by released by Meta and Google and OpenAI, all of these are released. These are mostly trained on Western data, and Indian data is currently not available to that extent that the AI can add significant value, and there is contextual limitation as well. But where can it actually help? There are focus on the production of the information or knowledge resources, which is the research division, where simulations can happen. A lot of simulated data can help. Data extraction is done quickly. Bibliography, encoding and decoding can happen very significantly because of AI intervention. And on the consumption, on the receiver end, on the actual practice that the doctor makes in their day-to-day life, in front of the patient, that's where AI can help in decision support, impact analysis, personalized learning for the medical fraternity, and automated data collection. Actual super intelligence come into the picture. When AI is meeting the human wisdom, information is rampantly available today at the tip of the fingers using Google, ChatGPT, Gemini, and other kind of systems. But wisdom that a human develops over a period of time, it is not easily shareable. It is not easily accessible to everyone. When the human wisdom meets the capabilities of artificial intelligence, then the actual magic happens, actual wonders can happen. Where can the wonders happen? On the human side, examinations can become quicker, assessments can become detailed, and it can help in early diagnosis and early screening. Critical reasoning and next best actions decisions can be made simpler with validated decision making possible as well, and contribution to further innovation and research advancements. Now we'll talk about few of the real life examples. Google has worked with Arvind Eye Care, and they have conducted a program using a concept called synergy thesis. The first level of screening is done by AI, and the second level of screening is done by a doctor. So they have taken the data, they have collected the fundus retina images of patients, and this is in real rural areas. And these fundus data were given to the AI model, and we have seen this doctor was an endocrinologist dealing with a lot of metabolic syndrome cases, and our AI has a lot of metabolic syndrome cases, and our AI has analyzed this entire data and have given them the subtle recommendations and inputs to establish this bidirectional causal relationship between sleep disorders and metabolic syndrome, because of which control or early identification of sleep disorders and rectification of that could result significantly in improving the outcomes of the metabolic syndrome and vice versa. And this was enabled because of the artificial intelligence helping the doctor in identifying the missed out subtle observations from the longitudinal record of the patient. Now, when a patient with metabolic syndrome actually visits the doctor, they might be coming with this thick of actual reports and records. And it will take a lot of time, and it is possible that subtle details are missed out by the doctor. But with AI, when this data is fed, it will run the complete analysis and give out the observations in a simpler manner. So now I would take an opportunity to introduce our products, which is Astra AI or Astra for the doctors, the ammunition, and Clinestra, which is a clinical data orchestration tool. These are two products that we have launched into the market, and for the last 3 months, we have got good usage, good utilization of Astra, which is a rapid decision support tool. Let me just give you a quick video. These are a few testimonials that we have received as well. So as you can see in this, the left corner, I have given the details of one patient to this without sharing any patient specific information, and I have uploaded an image of the x-ray, and it is giving me a quick interpretation, helping me in identifying if there is something that I have missed out. And in this way, it can help me build that entire patient case, and help me not just relying on artificial intelligence here, but actually relying on the medical literature and the best practices followed across the world, and taking their decisions, which might prove more efficient than otherwise. I would like your attention on a quick video.
I know. It's unfair that you are expected to access, process, and analyze 100+ data points within a few seconds. I know it's definitely unfair that you are expected to keep upskilling for the rest of your life. I know it's clearly unfair that you are expected to be right every time. I know it's completely unfair if 2 minutes is all you get to make decisions that can make all the difference between life and death. You are literally a superhero. Hey doctor, I'm Astra. Every superhero needs a loyal sidekick. We both can discuss about any case you are dealing with, and I will do my
So it is very true. My professor in emergency surgery also used to say that when you get a patient admitted, you should first look at the X-ray film and not the interpretation, because the perspective, the understanding that we might have on the patient might be different from a radiologist. And it is very valid point that the interpretation can keep changing as well. Where AI actually comes into the picture is, it is like looking at something from multiple different directions. That is what AI is currently trained on, from multiple different directions and multiple different fragments of the same image that it is able to visualize in a much better way. So AI tool today, whether it is radiology or pathology or any laboratory analysis for that matter, should only be considered as a second validation when we might think that we might have missed out on any specific detail. This is what the validation will help in making a conscious and confident decision making. That's where AI comes into the picture. And the type of images, the type of data that it is trained on, very well determines the capability that it will give as an output as well. Like we have discussed earlier, that if it is, I think our Prime Minister have actually spoken this in one of the conference, where he said that I have asked ChatGPT to generate an image while I am eating, of me eating with left hand. And it was not able to do that. It generated with the right hand. And why did that happen? Because the data that it is trained on is of people eating with right hand. So it was not able to detect eating with the left hand. And similarly, if we use it in the healthcare context, if we are able to give all the possible case scenarios, even the edge case scenarios to it, and good number of data, and we train the model, that is when it will be able to give you a decision on that from the expertise it is having just by viewing those patterns. Pattern recognition is the capability that the AI has. And when it comes to the decision making point of care, it is actually helpful to the doctors in case of any small doubt that the doctors have. It is not that the doctors cannot be taken otherwise. It is just that when it is validated, when in doubt, the reason we get some blood investigation sometime, the reason why we get some radiological investigation sometime, rather than directly making a decision, it is to see if we get some more information about the patient's condition. And that's how AI will be able to visualize and help in the decision making process. And Astra AI is just a tool that is analyzing the laboratory reports, urine analysis, stool reports, ECG reports, and X-ray reports with using different models, and it helps in suggesting recommendations to the doctor. This is an assistant to the doctor. So doctor is ultimately making a call on the decision, on the final decision. And doctor again is making this decision basing on the complete clinical correlation, as we very well mentioned on the image, radiology reports and others as well. I hope I answered your question.
Yeah, of course, I got my answer. I just have one question. Like, how long has this Astra AI been in the field?
This is a product, this is an AI agent which is working based on a foundational, there is a model that is running in the background. This engine was developed since the last 3 years by a group of 20 plus doctors who are working with us. And this was validated by 100 doctors. And after the thorough validation, thorough clinical validation, it was released into the market just 3 months back.
Okay. In these 3 months period, are there any instances where the AI interpretation was missed by the actual radiologist in person?
So we have not given this for the radiologist in this few periods. This was used by a lot of specialists from 16 different specialties, and unfortunately we did not have radiologists looking at it. Okay. We have physicians, specialists and super specialists from multiple friends who have observed this. And to give you a specific example, dermatologists have found it very, very useful when dealing with the cases where they don't deal with only skin related issues but other systemic conditions that the patient would come with, and they have to give something, some advice to the patient, and can't let the patient go further. It has actually recommended and negated 1,300 adverse outcomes from happening by giving recommendations to the doctor and doctor making the connections. This is the way in which we have worked with these 16 plus specialties.
Okay. Thank you, ma'am. Yeah.
Thank you. Yes, doctor.
Thank you for the talk. There was a lot of newer points which we were not previously aware of. But there were a few points about the AI program itself that I had. Where is it actually hosted? Is it the program, is it completely on a hardware, or is it on a cloud? Is it primary software? Is it all kind of sourced from an already pre-existing program, or is it completely in-house built or completely self-trained module, which I wanted to ask?
Yes. So first of all, this is hosted on cloud. Because the compute power is currently not doable on a hardware, but we are figuring out ways in which we can give this in the hardware itself so that offline decision making also can be supported, and we are working on that. Since we are a startup now, we have limited bandwidth to do that. And coming to the second question, we are definitely basing this from the foundational models of different OpenAI, Meta, and Google foundational models. But we have fine-tuned the model in such a way that it is now, this is an AI agent doctor. So AI agent does multiple functionality, multiple capabilities. It has large language models. It works with basing on the foundational models, but within a purview on limitations or the goal that it is built for, it will be able to act upon that only. And for that, we have multiple small agents working in the background, which will do the actual search of the medical literature, guidelines like PubMed and other databases, get the drug databases and different guideline related databases. It searches all of them and gives the answer in such a way in a natural language communication. So these are multiple models that are working together, and that's the reason we call it as a sidekick for a superhero. We call it as Jarvis for an Iron Man, and Astra is for doctors, because it does multiple small activities, smaller agents putting together and giving the ultimate value.
So the reason why I asked that was I've spoken with some other people who are incorporating it purely in the tech sector. When they're using AI to kind of help build programs, not for medical reasons themselves, there is an issue about data sharing. So for tech companies, when they have clients and they're using AI to build programs, then they might end up sharing confidential client data onto a cloud when it's hosted on a cloud. So similarly, in the medical field, when the primary AI platform is on a cloud, what about the data confidentiality of any programs which are based on that? When you upload it and it's entirely processed through the cloud, what about the data confidentiality, which questions will likely come up?
Yes, absolutely. That's a wonderful point that you have raised. So Astra particularly is designed in such a way that it is following all the instructions on the data protection guidelines as well, given by European and Indian counterparts, as well as US counterparts as well. So as I mentioned to you earlier, there are multiple agents working in the background, right? One of the agent is the one which scouts, handles the entire compliance. It makes sure that there is no confidential information, the patient specific information that is being stored, and this interpretation is only happening in the transit. And this is how we ensure that the data protection guidelines are being followed to the dot, and the real information, the identifiable information of the patient are not reaching or not being stored at any area. But this is a critical point that comes into the picture when we are dealing with patient information using our other product, which is Clinestra, where we store patient data, patient identifiable information also. But when it is shared through different segments, we follow the guidelines that are given by DPDP and other bodies, which talk about, the ultimate ownership of the data lies with the patient, and the patient consent has to be taken when it can be shared across to any different user. Even if it is another doctor that is treating the patient, it has to go with the patient's consent. And this is how we make sure that these multiple agents are helping us not to miss out and not to share any reliable information across. I hope it answered. Thank you. Thank you, everyone.
One question here.
Yeah. So I just went through the Astra app. It's a brilliant app, I would say.
Thank you.
Just few things that came into my mind while in this brief time when I saw that. Based on the knowledge database that the result is being given when I pose some question to the system app. So it is definitely extracting particular response from the copyrighted content. How did you take that permission, or you say, how do you claim the authenticity of the answer that it gives? Because if it is open source, which is based on which you are giving the response, then it would be as good as a Google search, I would say, just on this thing. So based on maybe standard literature or standard textbook or even the medical journals based on which you are providing the response. So which are most of them are copyrighted content. How are you dealing with that, and how are you giving the response based on the copyrighted content's information? Thank you.
Isn't that a trade secret? Anyway, I'll answer that question.
Not from the trade secret point of view. I'm just curious to understand, because that includes various numbers of publishers,
Absolutely.
may it be the textbooks or may it be the journals. It is humanly, I feel, humanly a very huge cost involved process, labor involved process, and technology involved process.
Yes, absolutely. And that's the reason we said that what we are able to reach so far is just tip of the iceberg, because there is a lot to do. And that's the same case for Astra and our AI platform as well. So how we are currently addressing this is with partnership established with these databases, certain journals and certain bodies which release the guidelines as well. And we are currently working with these partnerships, and we are trying to strengthen that further to be able to use the content. And what you are currently able to see mostly would be open source data, but which is validated by the 20 plus doctors that I have mentioned who are working as research partners with us. They for almost an year we have worked with these doctors and curated a database of 20,000 diseases from the origin of the disease to the end management by looking at storage of the data, interpretation, and how the disease progresses. The entirety is been designed using these doctors. So this is why AI in healthcare is always a collaborative functionality, because we need multi-skilled professionals coming together and working on something. And that is something that we have followed for Astra AI as well. I hope that answered. Thank you for your questions. Another question? At last, some student is asking a question. I'm happy.
Good afternoon, ma'am. I'm a final year MBBS student from ESI. My question is that how is Astra AI useful for students? And if we in fact use it and if we rely on it too much, whether it'll, decrease our knowledge, or whether it'll decrease our capacity to remember things or to interpret it in a better way. Like as humans, we tend to do mistakes and then learn from it. Do you think that will be reduced, or our intelligence will be reduced, or it will help us, or we can actually rely on it or not?
Thank you. First of all, a big round of applause. Sorry, I didn't get your name.
Ma'am, I'm Kaustuba.
Kaustuba, thank you very much for your question. I'm happy that a student is asking this, because most of the time faculty asks this question, that if we give something for the students, wouldn't their actual mind become numb and they can't actually make decisions? And a student actually asking this is very encouraging, and we are seeing a positive outlook on the future now. So yes, when you overly depend on something, there is always a risk that we will become obsolete. And I think that is one of the reason that there is a lot of fear among users of artificial intelligence as well, whether it is for writing a leave letter or whether it is sending a small WhatsApp message in our WhatsApp groups. We keep depending on ChatGPT kind of systems a lot. So similarly, when you overly depend on something like this, forget about artificial intelligence. If you overly depend on lab investigations also, not actually judging the case by looking at the entire clinical picture, then your ability might eventually keep reducing. So you have to look at it as another tool that is available in your arsenal and use it efficiently. That balance is always in your hands. That balance cannot be given by any regulatory body, nor management, nor legal frameworks can give that superpower, or not technology can guide that. And definitely not makers of this product, who would say that you have to use this product continuously for every decision. That depends on how you do it. And to enable this, we are all just enablers to help you make the best decisions. And again, you are also an enabler to what? To ultimately giving the best health outcome for the patient, right? So all of us have to use this very efficiently. How Astra helps is by giving you a clinical reasoning behind why these differential diagnoses, why one particular differential diagnosis is having a higher probability compared to the other, why considering the other alternative pathways is also required, and why specifically for this patient. This understanding is something that this can help with, which is very much required in the student journey. And ultimately, when you keep making your decisions for the patients, you will be arriving at a point where you might not need the support of any other tools as well. So it is just finding that right balance that you'll have to do.
Thank you so much, ma'am.
Thank you. Yes, ma'am. China-based.
Accessible to everything, and it also analyzes very well. And ChatGPT, we all know it does. But what I as a teacher say, I am not talking as a physician. I'm not talking as a consultant. I am just talking as a teacher. What I would suggest is when you are doing a post-graduation, that time you should start using. Okay? But as Dr. Akhila very correctly said, it is not just in post-graduation as a whole, because the onus lies on you. It is not just the onus of medico-legal issues, it is the onus of handling a life properly. That is very important, right? So, undergraduate, you have to build up your undergraduate because you still lack your clinical knowledge. You cannot use AI unless you have got a good clinical foundation for yourself. That includes history taking, physical examination, and then application. Then comes the role of differential diagnosis, treatment, and management. So postgraduate, yes, again, it is a tool, or postgraduate or till your grave. This is just a tool, but a good tool. Still, as I said, it is in a toddler stage. It has to evolve much more, much more, because it has you got to have data from lots and lots and lots of people. Because a case will be looked from different eye, like I gave you an example. So that is very important. Fantastic. Thank you, Dr. Akhila.
Thank you, ma'am, for showing how AI supports decision-making and workflow efficiency while reminding us of the importance of validation and patient safety. I invite Dr. Rajiv Kumar Bandaru, sir, to present the token of gratitude. Thank you, sir. Thank you, ma'am. Moving on, healthcare is built on trust, and trust is built on protecting patient data. India's new data protection law is vital because it ensures lawful processing and consent, purpose limitation, security safeguards, and respect for patient rights, all of which are critical for telemedicine. To guide us through this, we have Ms. Ifrazunisa Khan, ma'am, founder and counsel of Initial Legal Services with a master's in corporate law from the University of Cambridge and nearly a decade of corporate legal experience. Ma'am will speak on understanding India's new data protection law. Welcome, ma'am.
Hi, good afternoon, everyone. My name is Ifraz. I know it's been an intensive session since morning, so I will keep my presentation a bit brief, and probably together we can learn about the law through question and answers. So just starting off, we've heard a lot about data privacy, sharing of personal information, by physicians, by patients, between doctors, institutions this morning. And to be very honest with you, till now, India did not have any law, a codified law to regulate this. So we had snippets of this across various laws. So you have the Consumer Protection Act, which says you have to maintain confidentiality of patients. You have the telemedicine guidelines, which also speak about taking consent from patients while using their information. But for the first time, the Indian government finally woke up and realized that we need a codified law to protect personal information and data privacy. And that was when the new Digital Personal Data Protection Act came into force. Now, what is personal data? So, it can be your radiology reports, it can be your retina images, it can be your blood reports, it can be, medical history, but it can also be something as simple as a person's name, age, gender. These are all personal information. This all ties to a specific individual. So it's not just, very serious information that you would collect as physicians, as medical institutions. It would also be something as simple as, okay, taking a person's credit card information for processing their bills, taking their email address for sending them a report, taking their mobile phone number to keep them updated on a doctor's appointment, taking their name, taking their gender, taking any medical history that they may have. So it can be as simple as that. Now, what we need to understand is how do we collect this personal information? How do we use it? And then how do we even destroy it in accordance with law? Now, you may be wondering what a lawyer is doing in a room of doctors, but I come from a family of doctors and I feel very at home today. And for the past 10 years, we've been working with hospitals and medical organizations to just ensure that a robust system is in place for taking and sharing this kind of personal information. But why is it so important for the healthcare sector? Because you're dealing with more personal information than any other organization, than any other individual. You routinely collect personal information because every day you have patients that you need to look at, you have hospitals, you have clinics to manage. Every day you're collecting personal information, you're processing it, you're sharing it, you're storing it. So the liability in terms of law is much greater on healthcare professionals, on medical organizations, and also because of the sensitivity of information that you're handling. You're handling someone's medical history, you are, organizations who are involved in clinical trials are handling a person's life history. It is very sensitive information that gets handled day to day in pharma, for example, industries, medical industries, healthcare sectors. So the risk for breach, the risk that you may be non-compliant with law increases. And this eventually leads to penalties. This leads to cases being filed against hospitals, against doctors. This leads to criminal complaints. This leads to, on the other side of the coin, a reputation damage for a hospital, for a doctor as well. So what exactly is the new law? What exactly that you need to do now? Well, you are taking consent, right? That consent is there in your patient forms, in your admission forms. Whenever a patient goes for surgery, you take waivers, etc. All of that is consent. But now what the law requires you to do is take specific consent. It needs to be detailed. It needs to be very granular. You need to tell the patient exactly what you're taking from them and exactly how you're going to use it. Whom are you going to share this with? Exactly how this is going to be stored and when is it going to be deleted? Because now you cannot store this information perpetually. So you cannot take someone's information, put it in a file or a folder, put it in a record storage room and forget about it. It needs to be destroyed once it reaches the end for purpose. So you take someone's information for treating them. Once the patient gets discharged, do you need that information? No. Probably you can retain it for some time in case for follow-up visits, but after some point it needs to get deleted from your system. You cannot store it permanently. I think we got one question from Dr. Rahul as well. Where are you storing this information? Which is also very critical, because now what India is saying that you cannot store it outside India. You can only store it outside on foreign servers for the countries that we allow you to. So for example, tomorrow India says you can't use Chinese servers. So you can't store it on any Microsoft server that's based in China. So there's a lot of push for localization as well, that you need to start using companies, cloud servers, etc. that are based in India. And you track the information that is flowing outside India as well. Then right to withdraw consent. Now this is also very critical because this is something which is new. Now if a patient comes to you and says, I'm not comfortable with you having my information, I want to withdraw my consent that I've given you. They have a right to do that now. So now you need to go back in your system and figure out, okay, where have I stored this guy's information? How can I delete it? Because now legally they are allowed to come to you and tell you to delete their personal information. And you would have to comply with it. So what are the rights of patients? We've discussed right to take consent, detailed consent. Then they also have a right to access your records. So they can make a request to you, to a hospital, to a practitioner that, okay, I want to see what exactly you've collected from me. How have you stored this information? What are you doing with it? They have a right to access the health records in case they feel something has been incorrectly captured by you. So the name is wrong, their medical history is wrong, their father's name is wrong, their age is wrong. All this is personal information that you've collected from them and they want to update it. They can do that. They can come and ask you to do that and you cannot refuse because legally now they're allowed to do that. Then right to withdraw consent, we've talked that they can come anytime, ask you to delete their information, and you will have to ensure that their personal data is deleted from your system. And then right against commercial exploitation. Now this is very important because I know for a fact that if I go to a hospital tomorrow, they take my mobile number and then they may just use it for spamming me with advertising material. We have this scheme going on, we have this camp going on, we have, these seminars, this marketing event coming up. Now all of this is something that I've not given my permission to you to use my data. I've given my data to you to diagnose my condition. Now you've taken my mobile number and you're using it for commercial purposes. So this has now been strictly forbidden. Unless you upfront inform a person that you are going to use their business number for these purposes, unless you take their specific consent for that, now you cannot use their personal information, their business number, their Gmail address, whatever, to send them these marketing materials or just use it for any business or commercial purposes for which you have not taken their consent. So what are your obligations now? So what do you do as doctors, as hospitals, as medical organization owners? So one, you will already have a system in place of consent. You just need to make it more robust. You need to go back, you need to see whether your consent forms are detailed enough. Do they need more updation? In case of an app, you need to look at your privacy policies. You need to look at your disclaimers. What kind of information you're taking? Does it need to be updated to be aligned with the law? Secondly, you need to then also look at your IT systems. Are they equipped enough to protect this personal information that you're taking against any cyber attacks, against breaches, against unauthorized access? you have to start also now appointing specific officers within your organizations. These are called your data protection officers that will be responsible for all this compliance. And in case you have a data breach, you need to inform the patient that your data has been compromised. And you also need to inform the government that you have suffered a data breach. So the new law says that there is a specified time period, 48 to 72 hours, within which you have to inform the regulatory authority that you have suffered a data breach. Now we're talking in context of telemedicine as well. And telemedicine is, primarily more impacted by these new laws because everything is virtual. Everything, is consent is usually taken either in the form of a hyperlink that they send you, or, it's taken visually. Someone may just ask you over a call, oh, do you consent? And you say you agree. Now, all of this needs to be revised and revamped as well. So yes, we do have the telemedicine guidelines, which came in 2020. There's been no update after that. There's been no law as such as well in context of telemedicine. Largely, it remains unregulated as of now. But because of this new data privacy law, it will capture these telemedicine platforms as well. So what do telemedicine operators need to do? Well, again, they need to ensure that they are taking proper consent. So if you're a hospital or a practitioner who's working with a telemedicine platform, you need to ask them this question. How are you taking this consent? Okay, how are you managing your privacy? Where is this information being collected? Am I at risk? So if this data gets compromised, am I as a doctor or a hospital, because I'm using your service, do I get compromised? Can a complaint be filed against me, even though I'm not at fault? Now the penalties for non-compliance. So this is where the kick is. Because right now, the government of India was sleeping on this whole enforcement. But the new law says that penalties will start from 100 crores, in fact. Yes, it will depend on the nature of offense. It will depend on the nature of organization, who was involved, etc. But in fact, the penalties that they've laid out in the new law, the beginning itself is 100 crore threshold. And these are just the civil penalties. You also have criminal penalties as well, which get enforced under other laws in case of a breach of confidentiality and compromising of patient privacy, private information as well. Compliance, benefits of compliance, well, no jail and no money penalties. Those are the benefits of compliance. But just on a lighter note, I think just on a more serious note, compliance is an evolving mechanism. This law is new, so we are yet to see how the government is going to enforce it, how it will be interpreted, how the courts will, adapt to this new law, how will the courts pass their judgments on it. So compliance is an evolving mechanism. But what your starting point needs to be is just go back and see as doctors, as professionals, as students, what are the existing frameworks right now that are in place? How much more do you need to adapt and improve them? So these are some of the immediate action points you can consider. You can consider updating your privacy policies, your patient consent forms. You can train your staff, your doctors, your nurses on how to handle sensitive information. Bring more awareness that this is the nature of personal data that we're handling and it needs to be handled in this manner. That it is critical that systems need to be put in place and all the staff needs to be complying with it. If you are onboarding any external service providers like cloud servers, any external agencies who sort of do this groundwork for you, then you need to go back, you need to start questioning them, see your contracts, your agreements with them to see how these aspects are captured. And then you also need to update your IT systems. So in case there is a data breach, your system will send a trigger to you that personal information has been compromised. And lastly, appoint data protection officers in your organization who will be the sole point of contact for government authorities in case the government wants to contact you on this matter. So I think that was my very short presentation, but I am happy to take questions if anybody has them. Yes.
Yeah, thank you, ma'am, for elaborating us on the data privacy concerns. I have one question on the particular statement that you made. The data has to be destroyed.
Correct.
Does the law mandate that?
Yes, it does.
Okay. Now, for us doctors, or maybe for any future learner, this is a learning for the posterity, isn't it? The
Correct.
clinical data, what we gather over the period of time, all the clinical records, those are used. Those are a fertile ground for research.
Correct.
And research is something through which we learn.
Correct.
So what is your take on that?
So the law provides an exemption for research purposes. In case you're collecting and storing information for research purposes, but then again, at the time of taking consent, for example, I come to you with a medical condition. You want to store my case file for, educating graduates like young doctors, or pass it on for clinical trials, etc. At the time I give you this information, you have to take my consent. So when that consent form gets signed, it has to specifically mention that your information will be stored by us for research purposes and may be used for clinical trial purposes as well. So that, yes, you can do it, but provided you take my consent for it.
Okay.
I have a small question on the data breach. You were mentioning about the data privacy and data breach. Now, what kind of a data are we talking here? Is it a user data or a clinical data? If it is only a user data, then why in healthcare? So everywhere it is a breach then. Then why are we talking only in healthcare?
You're correct in saying everything everywhere is a breach. So for example, social media organizations, Facebook, Instagram, right? They will be impacted by this because they're collecting, images of people, correct, on the social media platforms. Banks, for example, will be impacted by this because they are collecting your financial information. The emphasis is more on industries like healthcare, medicine, pharma, because you're handling sensitive information, which is person's diagnosis, their medical conditions, etc. So while all data is important, it's personal data, all of this is subject to equal liability. When it comes to enforcement, it is a high probability that the regulatory body will focus more on sensitive industries like pharmaceutical industries, healthcare industries, etc., when it comes to scrutinizing any complaint. So we have a new body which is coming, which is the Data Protection Board of India, and they will deal with any complaints that I as a user file. So for example, if I as a user file in respect of a hospital or a medical organization, the gravity of that complaint increases because it deals with a much more sensitive information. Yeah. So it's just from a regulatory enforceability perspective that the emphasis is stronger on certain sectors and industries.
Okay. Now we are talking about a human breach. This is more on the human breach. Now we've been coming across a lot on the structure, where security, privacy, SSLs have been provided. Now when you talk on, let us go back to the history and this transition. We are talking about say HL7 and HIPAA. Now we have HL7, you have HIPAA, and again you have. So what kind of advancement or improvement is done there? Now, if you have a proper system in place in the beginning itself with your structuring, then you don't have to go for what you call the human bridge. So human bridge can happen anywhere, even at a government servers also. Human bridge can happen. And if you impose this kind of a data, you are talking about a cloud, then impose only on the NIC servers. Now, why you are allowing the private servers like the AWS or where they are multinational, they have their what you call their servers at different countries, and again you allow AWS in India, you allow AWS in Dubai, where they are all connected. Now, how do you address to this, and how security is provided here?
So two aspects to that. I think one is when it comes to using outside service. I think the intention of law is protection of personal information. So irrespective it is government body, it is a private institution, all of them are equally liable. So for example, even if it is a government institution that has taken your information and has mishandled it, the law actually allows you to file a complaint against the government itself. So that means there is no discrimination between private and government bodies. Equal treatment with respect to handling of personal information. When it comes to dealing with, I'm sorry, you said you started with user data, right? Human data.
Right.
So with respect to human data, what has happened is that even though we use external service providers, the liability is on us because we are the first point of contact for any user, right? Because we are collecting that information. Yes, we are passing it on to servers, we are passing it on to external service providers, etc. But that is a back-to-back arrangement, right? We are liable because we are the first point of contact. We are the ones who are actually collecting this information. Now, whether it's human data, whether it's any other form of data, unless it's anonymous, it's equally important. So if you have information that you can tie to me, for example, you have my name, you have my Aadhaar, you have my PAN. So this is information that you can identify me with. So that is your personal information.
One last question here. Like, the data breach is done, and you think the user is aware of it? What has happened behind?
In some instances, no. Not many, because we don't have, the technological softwares that like for example, you would see Google having multiple data breaches. We don't even know our Gmail accounts are compromised. So unfortunately, at individual level, we can't determine if our information has been compromised. That's why the law says that if Google faces a data breach, it has to notify us. So we know that our personal data has been compromised. Yes, sir.
Okay. I'm going to ask you a few questions. Thank you. It was a very interesting talk. And then I think it's very important for telemedicine as it progresses that these rules have to be followed. So in that context, we are doing rural telemedicine. In that, electronic health records is very, very important, as we all know. So for that, in the demographics, so we have to take a particular private or personal information to identify the patient when he comes. So currently we are using Aadhaar card. Do you have any suggestions?
Aadhaar
using
card,
a particular
Aadhaar card can be used, sir. Aadhaar, PAN, etc. The only condition is that when they're giving you this information, you simultaneously ask them to give you consent. Consent. So if it's happening online through a platform, usually a consent notice is given. So you can put it as a hyperlink, or you can attach it to that platform saying, please read this, give your consent, and then give us this information.
So another question, sometimes, patients may refuse Aadhaar card. What is the option in that particular case? Because Aadhaar, you identify that is the link where you identify this. Of course, we put a photo and all those stuff for correlation, but Aadhaar is the base. What happens if the patient says, no, I don't want to give the Aadhaar card?
Well, they have a right to refuse to give them.
So they have the right. So
correct.
If they don't, so then we say it's okay. We have to use alternative measures to identify the patient.
Correct.
Because we are using Aadhaar card to link everything.
Yes. Because I think Aadhaar is also used for the purposes of availing insurance, etc.
Correct.
Right? But if I am unable to give you my personal information, and you say that, but we need this information for giving you this service, we don't have your consent, then unfortunately we cannot give you our service.
So that makes it hard. Okay. So probably, hopefully, down the line they have something, because that's the key. I think probably universal health identification numbers are being given, I think.
Yeah, right.
So do you have any information about that? How do you go there? And then where the patient, I heard, is given from the birth a unique identification. Maybe I'm taking too much of their time. I'm going to cut short. So that's a very, very important critical link for the electronic health records to do telemedicine in rural areas, is giving a specific identification number. Everything goes according to that.
Right. There are in fact guidelines on maintaining electronic digital records by healthcare service providers. These are more advisory in nature, more IT system sort of oriented, more on the technical side. But there are guidelines, and probably I can share these with you.
That's the last thing is, if I can share your contact information, will be very helpful going forward for you to take your guidance. And then so the other important thing is consent. So that is the basic first thing. As soon as the patient comes in, you take the consent. So the problem with what we are dealing with, these are rural people, they are not educated. So even sometimes they cannot read. Telugu and all those stuff. In that particular case, what is the option we have? That is the most important thing.
Correct. So it's very interesting actually, because the law says that you don't actually have to take consent in English. It can be any of the 28 or so languages.
I'm so sorry. I hate to interrupt you, because because the people can't read.
People can't read, then someone would need to explain them. That consent, it need not just be in writing, right? It can be in the form of a paper. Sorry?
Can we take a video consent?
Correct. So you can have someone explaining the contents of the consent notice to them, and you can take their consent through oral confirmation as well.
Video is okay?
Yeah.
We can explain all the stuff, make the patient listen, and then come and say, okay, video consent is all right. And then, so Disha, so probably, we are aware of HIPAA. So what is that? Now, Disha rules have to be followed. What specific rules? I'm sorry, maybe it will be very helpful, since it's a telemedicine meeting. I'm going to take a little time if it's okay with you. Sorry, Krishna.
Sorry for the interruption. Actually, we are missing the time. So let us stick to the points. Then whatever questions are there, we can do it during lunchtime and networking time. Okay. Thank you very much. Thank you all.
Thank you. I'm sorry. Hope I didn't take too much of your time. That's very interesting questions, and thanks for the talk, man. It was very, very interesting.
May I request Mr. M.V. Sharma, sir, to hand over the token of gratitude to Ms. Ifra Zunisa Khan, ma'am. Oral health is often overlooked, yet it is deeply connected with systemic health. Conditions like diabetes, cardiovascular disease, pregnancy outcomes, and even respiratory risk are linked with oral hygiene. With integrated care and digital tools, this connection is becoming more important than ever. To share insights on this, we invite Dr. Snigdha Mokapati ma'am, Clinical Lead and Director of MedMock Enterprises, with fellowship in medical cosmetology, anti-aging and healthcare management. She is currently using her expertise in driving clinical advancement at MedMock, integrating health with technology. Ma'am will speak on effect of oral health on general health. We welcome you, ma'am.
Good afternoon, everyone. I hope you're all doing good. There? Excuse me? Full screen.
Yes.
Okay, thanks. Okay, myself, Dr. Snigdha Mukhapati. I'm the clinical lead and director at MedMock Innovations. So my journey from MBBS to aesthetic medicine and healthcare management in ISB has shown me how oral health serves as a window to our systemic well-being. So today, we'll explore how oral health is closely linked to overall body health and why medical professionals must recognize its systemic implications. And also, let's see how technology can help bridge gaps in early detection and prevention. So let's start with the global picture. According to WHO, nearly 4.1 billion people, that's almost half the world's population, are suffering from oral diseases. So dental caries and permanent tooth is the most common health condition globally. And gum diseases, tooth loss and oral cancers add to this burden. So these aren't just dental problems, but they are linked to cardiovascular diseases, diabetes, and many other systemic conditions. Yet, oral health remains as one of the most neglected areas in the public health. So in India, the situation is even more concerning. About 85 to 90% of the adults have dental cavities and nearly 60 to 70% of the children have dental caries. So oral cancer ranks among the top 3 cancers in India, and it is largely due to tobacco and betel nut use. So only 5% of the Indians visit a dentist regularly, and that too only on an SOS condition. So there's a lack of awareness, poor access in rural areas, cultural habits, and high treatment costs make oral health a low priority in our healthcare system. So let's discuss the most common oral diseases in India. So number 1 is dental caries or cavities. So bacteria in our mouth, so it combines with the sugar molecule and erodes the tooth enamel and forms a hole on the surface of the tooth. And this is called a cavity. And the second one is gum diseases. So there are 2 types of gum diseases, gingivitis and periodontitis. So gingivitis is the swelling of the gums, and when this is left untreated, it will lead to periodontitis, that is involving the underlying bone. And it can also lead to tooth loss in future. So the next one is malocclusion, misalignment of the upper and the lower tooth. So this will affect chewing as well as the speech. Next, the fourth one is tongue ailments. So tongue ailments like ulcers, any burning sensations, or any infections. So these are all, these can be prevented early, but if they are detected early. So what do you think are the most common causes for this massive oral disease burden? Poor oral hygiene, high sugar consumption, tobacco and alcohol use, lack of preventive, poor oral health to overall systemic health, causing cardiovascular diseases, respiratory diseases, diabetes mellitus, CKD, that is chronic kidney disease, and autoimmune conditions, pregnancy complications, neurological disorders, and even psychological well-being. Let's look at the first connection between the oral and the cardiovascular health. So conditions like periodontitis, dental abscess, or even routine dental extractions can create micro tears in the gums. So periodontitis and untreated oral infections, they can cause chronic inflammation, trigger immune reactions, and promote plaque formation in the arteries. That's also called as atherosclerosis. So this will increase the risk of coronary artery disease, infective endocarditis, and the bacteria which causes infective endocarditis are Streptococcus viridans and Enterococcus and HASIC group. Can anyone of the 4th years or someone tell me about what species are included in the HASIC? Haemophilus, Agrigobacter, Cardiobacterium, Echinella, Kingella. So these are the main species. So they can enter the bloodstream through poor oral hygiene or any of the dental procedures. So they colonize the damaged heart valves and endocardium, causing infective endocarditis. And this will also increase the risk of myocardial infarction, stroke, and also hypertension. So therefore, a healthy mouth indirectly protects your heart. So now let's look at the next connection between the oral and the diabetes mellitus. So the relationship between those both are bidirectional. This is because a gum disease will raise inflammatory markers, worsening insulin resistance and blood sugar control. On the other hand, diabetes will promote bacterial growth in the mouth, delays healing, and increase the risk of oral infections. So here, managing one condition will improve the other condition, and this is a vital message for both physicians as well as the dentist. Next, let's look at the connection between the oral and the respiratory disorders. So, oral bacteria don't just stay in the mouth, right? They can be inhaled into the lungs, causing pneumonia, bronchitis, COPD, and many other ventilator-associated infections, and that too especially in hospitalized or elderly patients. So, as you all know, that upper respiratory tract has a very good immune defense compared to the lower sterile respiratory tract. So, good oral care in ICUs and nursing homes can reduce respiratory infections significantly. The next connection is between the oral health and the pregnancy. So during pregnancy, there is an imbalance between the estrogen and the progesterone hormones. So this can make the gums more prone to inflammation. This is due to gingival hypertrophy. So any gum disease, these inflammatory mediators will travel to the placenta. So these signals can affect the placenta and uterus, interfering with the normal pregnancy. So oral bacteria can enter the amniotic fluid, increasing the risk of preterm births and low birth weight babies. So oral care must be a part of antenatal care, that is to protect both mother and the baby. The next one is the oral health and the neurological disorders. So chronic oral infection and bacteria like Porphyromonas gingivalis can cross the blood-brain barrier, and it can lead to following diseases: Alzheimer's, and then stroke, Parkinson's disease, multiple sclerosis, and also brain abscess or meningitis. So here severe dental infections, they can spread to the brain, causing life-threatening infections too. So protecting oral health may support cognitive and neurological health in the long term. Now the next one is the link between the oral health and the kidneys. So gum diseases and chronic oral infections, they release harmful inflammatory byproducts that increase the risk of kidney damage. So in CKD patients, that is chronic kidney disease patients, weakened immunity and reduced healing make gum diseases more severe. So diabetic nephropathy, polycystic kidney disease, glomerulonephritis, and severe oral infection can also lead to sepsis that can suddenly damage the kidneys, that will decrease the kidney function, causing acute kidney injury. So oral care is particularly important in CKD patients who already have compromised immunity. The next one is the link between the oral health and the rheumatoid arthritis. So periodontal pathogens, they can trigger autoimmune responses. So these proteins, they can worsen existing joint inflammation in people with rheumatoid arthritis. So gum diseases, they may lead to more severe joint pain and stiffness. And also untreated oral diseases, they can make rheumatoid arthritis more harder to manage. So treating any oral infection may help reduce disease activity and improve quality of life in rheumatoid arthritis patients. Next, let's look at the link between the oral health and the gastrointestinal disorders. So poor oral health affects digestion right from the chewing to the gut microbiota balance. So this is here, the swallowed bacteria, it can worsen inflammatory bowel disease because of gut inflammation, that is through immune reaction and bacterial migration. It can also cause gut infections, as harmful bacteria can also reach the gut and infect the gut, causing gastrointestinal infections. So this will even contribute to GERD, that is gastroesophageal reflux disease, and also the nutritional deficiencies. Next is the oral cancer. So oral cancer, as we all know, it is driven by tobacco, HPV, and also alcohol. So it is often detected late because early stages are painless. So by the time the symptoms appear, metastasis may have already occurred. So regular screening and lifestyle changes are a key to prevention and early diagnosis. So here, let's talk about the psychological and social well-being. Oral health affects self-image, speech, confidence, and social interactions. Missing teeth, bad breath, and also chronic pain can lead to anxiety, depression, and social withdrawal, reminding us that oral health is not just physical but also emotional. So chronic oral infections keep the immune system in a constant state of alert, so diverting resources and weakening defense against other diseases. So good oral hygiene will reduce systemic inflammation and also improves immunity. Coming to the tongue ailments, the tongue reflects nutritional status, systemic illness, and oral hygiene. So conditions like glossitis, leukoplakia, macroglossia also signal vitamin deficiencies and airway risks or even cancer, making regular tongue examination very important. So let's see the initiatives taken globally as well as in India. World Oral Health Day and India's National Oral Healthcare Program took an aim to raise awareness about oral health and integrate oral care into primary healthcare, and also by addressing economic burdens which are caused by untreated oral diseases. The next one is the National Oral Health Program, which was launched in 2014 to 2015 under National Health Mission. So the main objectives are improve oral hygiene awareness and reduce disparities, reduce oral disease burden at district or sub-district level, integrate oral health with general health care, promote public-private partnerships. So here the next one is the Ayushman Bharat. So this was initiated by the Government of India in 2018 under the Ministry of Health and Family Welfare. So its purpose is to achieve universal health coverage and make healthcare affordable and accessible for all. So the initiative has two components: health and wellness centers that they deliver to the primary healthcare services, screening and prevention. And the next one is Pradhana Mantri Jana Arogya Yojana, where they provide 5 lakh insurance cover per family and per year for secondary and tertiary hospitalization. So here, our device, so to address all these screening gaps, our team have developed the D-Oral device, which is an oral screening device that can screen 6 major oral diseases. So we screen caries or cavities, gum diseases, first stage of the oral cancer, malocclusion, fluorosis, and tongue ailments. So it's a portable device which is hardly less than 2 kgs. So it is AI-enabled tool that allows primary healthcare workers to screen patients. So it supports all the National Oral Health Program goals, enhancing accessibility, awareness, and prevention. And it also empowers rural healthcare by enabling early detection in schools, PHCs, and community health camps in rural areas. So it is certified with ISO, CE, CDSO, MSME, IEC, and patent certified, ensuring reliability and widespread adoption. Coming to the workflow, our device is a user-friendly device. It's a self-driven one, so it will let you know which part of the quadrant to be screened. And then any layperson can easily operate our device. So the operator will capture around 25 to 30 images of each patient or individual in 5 to 6 minutes, and then upload all of them to the cloud. From the cloud, it will reach to the dentist who's sitting remotely. Now the dentist can see all the images, apply AI filter, mention his findings and the treatment plan. Now the entire report will be sent to the patient via email or SMS. So this bridges the gap between the rural and the urban healthcare division. So the main benefits by using our device are early detection of diseases, prevention of complications, affordable care, better health outcomes, and also large-scale community impact. So this device aligns with the national health goals and strengthens preventive healthcare. So we strongly believe that overall health depends on oral health. So thank you all for your attention. And together as a medical professionals, I think we can integrate both oral care and systemic care together and improve patient outcomes and have a healthier future for all. Thank you so much. Thank you.
Any questions from the audience?
Yes, ma'am.
Yes, sir.
You have spoken about oral health, which has a vast impact on the systemic health. Okay.
Exactly.
We all do know that. Now, I have seen plenty of doctors, practicing physicians, practicing cardiologists, neurologists, nephrologists, you say whatever specialty. No one talks about oral health. No one takes a history of oral health.
Exactly, sir.
And of course, I skip from that generic list because I'm not a practicing physician. So my question is, what is the incidence of oral health impact on the systemic health? So, as per WHO or maybe the worldwide global figures, or maybe the Indian statistics.
Exactly. So as I was explaining you that there is almost 4.1 billion people, sir, who are actually affected with the oral diseases right now globally. And coming to India, almost 85 to 90% of the patients, they are suffering with the dental cavities. So usually here, most of the dentists, most of the patients, they only visit a dentist on an SOS condition. So our concept of building our device is to screen the entire oral cavity by covering all the 6 diseases. So when you actually go visit a dentist, you go only on an SOS condition. So when you actually have a cavity, you go tell the dentist that you have a cavity. So his focus is only on the particular cavity and to fill that cavity. Who's going to look at the tongue or base of the tongue or the hard palate? So with our device, we cover the entire screening. So we cover the entire oral cavity and then we provide the report to the patient. So for your question, so the incidents actually I can tell my experience because when we developed our device, so we screened couple of the schools. School students and all. So there was a student who was 12 years or something, and then she permanently had lost a tooth. Like there was a permanent cavity, and her permanent tooth was completely lost. So, after screening so many schools and all, the dental caries or the cavities or the gum diseases, they have a higher incidence in all the young generation itself. It's due to all the food habits, also the poor oral hygiene, and also the lack of awareness about oral health. Yes, sir. Is there anything?
Okay. That doesn't really answer my question. What is the incidence I'm asking? Of linking the oral health to the systemic diseases.
Okay.
I don't know that.
See, it's actually a bit hard to answer this because we are figuring out the oral diseases, but I can just tell you the impact of how it showed on overall health. And as just like as you said, most of the doctors they actually don't know about the link, nor either they talk about the link about it. So it was also very hard for us to find out the incidence on how it was showing on systemic health. But there were so many journals which were supporting about this topic, like about how oral health is showing effects on overall health. Yeah.
Thank you.
Thank you, sir. Thank you. Any more questions? No. Thank you.
I'd like to invite Dr. Nagraj sir and Dr. Shivani ma'am to present the token of gratitude to Dr. Snigdha ma'am. Thank you, ma'am. It is our privilege to welcome a very special guest speaker, Dr. K.S. Hemabindu ma'am, who has graciously accepted our invitation to be with us today despite her demanding schedule. Ma'am is a health tech entrepreneur and founder and CEO of Angel Eyes, an AI-driven platform connecting people with the right doctors, and also the co-founder and COO of Salubrity, an award-winning startup incubated at T-Hub. Her ventures have pioneered AI solutions in nutrition, hair health, and digital care, and earning global recognition, including at the Global AI Summit 2024 and the T-Hub Hackathon. She's also led impactful initiatives such as the COVID home isolation consultation drive, a year-long mental health campaign, and a successful diabetic reversal program. Featured in Lifestyle Asia, India Today, She Fit, and Enadu Vasandhara, and winner of the Unladylike Women Award in Health and Wellness, she continues to work at the intersection of technology, health, and sustainability.
Ma'am, we are privileged to have you with us today. We now invite you to share your insights with us.
Hello, good afternoon, everyone. I hope the spirits are still up. So, actually in ancient time, I call it ancient because you'll understand why. people used to come, get their checkups done, check their vitals, and take a prescription and go home. But now, a patient comes along with his AI or ChatGPT to get the consultations done. So I think somewhere between taking the prescriptions and also with these chatbots answering, the AI always gives suggestions like, please watch 10 yoga videos and here are 5 sleeping apps. But it never gives you the accurate information of what actually should be done or whom to consult. So that's where I come in. I have worked at this intersection of healthcare and innovation and AI for almost 5 years now. And so I started off as a doctor, and at this innovation sector, I have come through, I think 5 years back, just before COVID, where we launched a AI bot to check the health records of the patients, whether all the vitals or the blood tests were there. So my first venture, Angel, I started off with that idea. And now we are currently developing a search engine to find the right doctor. So a person answers few questionnaires and then finds the right doctor in their own locality. That's what we're building. We are currently working with T-Hub to build this software. So this came from a very simple and powerful question: how people find the right doctor at the right time. So this was the question that is being answered by us. So as they mentioned, during COVID, we have collaborated with multiple doctors and done free consultations for home isolation cases. And later, we also ran a 1-year mental health drive right after COVID during the 2021 era, where we made the therapy sessions accessible and convenient. Mostly all the therapy sessions were online, so people could access it. And my second venture, Salubrity, is where we went deeper with AI. We have developed 3 AI bots. So one AI bot is a nutrition bot where you click a picture of your plate and it will tell you all the nutrient values that are there in the plate. And it will give you suggestions as to what you can add and what you can take out. And the second bot comes for the hair loss, where with your phone camera, you can actually click your pictures and the scalp pictures, and it'll give you the stage of hair loss and the density of hair, and it gives a very detailed report to the doctor as well as the client. And on the third bot, it is a portable trichoscope bot which clicks pictures of your scalp via your phone again, and it gives a more detailed analysis of how your scalp health is and whether regrowth is happening or not. So you can use any product in the market for hair, any shampoos, any serums, and check with our third bot whether the hair regrowth is happening or not. So that's what Salubrity does. We are currently, again, Salubrity is also working with T-Hub, and we were the proud winners of Hackathon 2024, and we were recognized at the Global AI Summit 2024 by the IT Minister as well. So what excites me in this innovation journey is I have found so many students from IIIT and also IIT working on healthcare innovations, especially in the oncology field, which is much needed in this generation. And that was so inspiring to see students at the age of 19, 20, 21 working with T-Hub to get a solution, basically also to make our doctor's job easier. Because AI, as quoted by Dr. Lingaya sir, director of Yashoda, AI, a doctor who knows AI will be replaced. I'll quote again, very sorry. A normal doctor will always be replaced by a doctor who knows or is in collaboration with AI. So that was his quote, and that inspired me a lot. Coming to the our website, and we are currently over on Instagram. You can check out Salubrity Health and Wellness, definitely. And so as we look ahead, I think India is at a place where we have the scale, the talent, the people, and also the databases and the information towards healthcare. And I see a lot of innovations happening in this field. And I think even with our cultural depth, we can definitely develop a more AI-driven healthcare, and we can probably connect other global leaders as well into this. So I'm here not just to showcase my startups, but to also invite collaborations. Let's build solutions with AI. So definitely reach out to me if anybody is interested in building and collaborating in this sector. Thank you.
Thank you so much, ma'am, for those inspiring words and for showing us how innovation and compassion can go hand in hand in healthcare. I'd like to request Dr. Sadhana Sharma, ma'am, and Dr. Akhila Kosuru, ma'am, to present the token of gratitude. They say the best way to predict the future is to create it. And through workshops like this, we are indeed shaping the future of healthcare.
Well said. And our speakers today are the very creators of that future.
We now come to a very exciting part of the day, the award distribution ceremony to honor our top 3 poster winners.
We request our dignitaries to kindly come forward and present the awards.
I request Dr. Nagraj sir to kindly present the awards. One is
second and third, we are not sure. First is here, second and third, we are not sure. But they are not information.
Just call their names. Are they here?
Yeah, call out winners' names. Are they here or not? Winners ఉంటే చాలా
I invite Mr. Uma Mahesh, Treasurer of TSI, to also present the award to the winners.
So the first place is backed by Kota Fani from ESIC. The second place is backed by Manogna and A. Jessica from Maheshwara.
Okay, two people, two వేరే third winner
The third place is bagged by NC Sarni from Maheshwara.
I invite Dr. Rajiv and Dr. Shivani ma'am to also present the award.
Krishna Rao. Yeah. Vote of thanks. Media partner.
May I please request Dr. Krishna Rao sir to hand over the token of gratitude to our media partners, Hybiz and Namaste Telangana also.
Token of appreciation to guests. Guest का नाम लिख लिया है ना? Radhika ma'am is not here. Radhika ma'am is okay. Ashwini, Dr. Nagaraj, Dr. Bhimupindi को दे दिया है ना? It's okay. Dr. Karna. But he's left. Okay. We'll just announce and then it's okay. Announce these awards and
Is it being given now? I request Dr. Rajiv sir to present the token of gratitude to Dr. Ashwini sir. May I now invite Dr. Akila Kusuru ma'am to present the token of gratitude to Dr. Nagaraj sir.
As we come to the close of this workshop, it is time to express our gratitude.
I'd like to invite Mr. Uma Mahesh, Treasurer of TSI Telangana, to deliver the vote of thanks.
Hello, good afternoon all. This is Uma Mahesh, Treasurer, Telangana TSI chapter. So on behalf of organizers, I extend my heartfelt gratitude to each and every one of you who made this event a resounding success. So I'm really sorry that I cannot name everyone here. The list is very big. So I'll go with the text itself. So to our distinguished audience, students, doctors, entrepreneurs, health tech enthusiasts, speakers, and esteemed guests, thank you for honoring us with your presence and valuable contributions. And your participation has truly enriched the discussions and learning. Thank you so much for making this event very successful. I did my best to convey this. Thank you. No, you can call them. Each one, all the leadership is Please come forward for the photograph. Yeah. Sponsors, photograph. And the organizing committee. Organizing committee and supporters.
Please gather for the group photograph.
Yes. Speakers also.
Speaker.